Good afternoon, everyone. On behalf of AOGD Fetal Medicine and Genetics Subcommittee and DODA Imaging and Healthcare Center, I welcome you all to this webinar on the basics of fetal neurosonogram and fetal MRI for obstetricians. So as we all know that fetal CNS anomalies are quite common, and to the latest data say that the incidence could be as high as 1%. And obstetricians, till now, they have been handling the ventriculomegaly, the neural tube defect. But with the development of the, with the new branch that is the fetal medicine, there are, the term coming up is the fetal neurosonogram. So today we will be sharing, what is the basics of the fetal neurosonogram. So first of all, Himanshu, I need the CVs. So I would like to introduce my co-chairperson, Dr. Sangeeta Gupta, who is a professor at Maulana Azad Medical College. And she has, the biggest credit goes to her that she has been able to establish the fetal medicine clinic at MAMSI and Lok Nayak Hospital, New Delhi, and has got vast experience in the invasive procedure. She has been awarded Common Health Scholarship in 2007 and trained in the fetal medicine at the St. George's Hospital, London. And she is a faculty of FNB training program, both high-risk pregnancy and perinatology, multiple publications and contributions to the various textbooks, an editor of the AOGD Bulletin in 2016-17, and member of a fetal medicine AOGD subcommittee, and currently she is the co-chairperson. So next slide, Himanshu. So I feel honored and privileged to introduce ma'am, though ma'am is not present today because she has to conduct the DNB examination and she's an examiner for that. But ma'am, as everyone knows, that she's a director, professor and HOD at Maulana Azad Medical College, New Delhi, and she is the current president of the AOGD Delhi. And her main area of interest is maternal fetal medicine, and she has got more than 50 publications and a joint editor of the 4 books and member of expert panels like UPSC, NBEMS, GNCT Delhi, GOI, and various affiliations in the form of like President Narchi Delhi. She has just finished her term tenure from 2020 to 2022, and AOGD Joint Secretary from 2004 to 2006 and 2010 to 11. And AICC's RCOG North Zone member representative 2009 to 2011 and fellow representative 20 to 23. So I welcome you, ma'am. Next slide, please. Dr. Deepti. Himanshu? Yeah. So today guest of honor would be Dr. Deepti Goswami. As I told that ma'am is busy. So she is also a director, professor and unit head in charge, Gynae Endoscopy Clinic and faculty of reproductive medicine at Maulana Azad Medical College, Lok Nayak LNJP Hospital. And she is the secretary of AOGD Delhi. And she has received Commonwealth Scholarship of Gynae Endocrinology at University College London Hospital. And her field of interest is Gynae Endocrinology and infertility. And she has edited 3 books in Obs and Gynae and has got publications in prominent journals, Human Reproduction Updates, Human Reproduction and Journal of Clinical Endocrinology. So she is in charge of endocrinology clinic. So now I request Dr. Deepti to give us the address the the session. Dr. Deepti, are you there?
Yes.
Yeah. So welcome, Dr. Deepti.
Good afternoon, everyone. I hope I'm audible.
Yes, yes, very much.
I'm very much delighted to have this opportunity to address the audience and the organizing team of this webinar. Dr. Seema, Dr. Sangeeta Gupta, Dr. Tina Verma. Fetal medicine as a subspecialty has evolved rapidly over the last 20-30 years. Integration of imaging, genetic, and lab studies have led to fine-tuning of diagnosis and management for various fetal malformations and disorders till now, about which we had hardly any understanding. In today's webinar, we look forward to deliberations by eminent faculty on CNS malformations. I congratulate the AOGD Genetics and Fetal Medicine Subcommittee for picking up this fairly common but enigmatic topic for discussion today. Thank you very much.
Thank you, ma'am. Thank you, ma'am. So Himanshu, next expert slide, CV slide. So I extend my warm welcome to Dr. Vanna Chadda, and who everyone knows, she is a known expert in this field, and she is a certified medical geneticist, and she is working at the Satwa Medical Center, and her area of interest is fetal imaging, fetal interventions, fetal therapy, multiple pregnancy, fetal genetics, and fetal autopsy. And she has got lots of awards like IMA Distinguished Service Award, IMA Young Achiever Award, DMA Best Worker Award, Chief Minister Award for Fetal Cardiology, and more than 15 academic active, and has organized more than 15 academic activities. And she has got publications, more than 20 in index publications like AJOG and Ultrasound Ops Gynae, more than 50 scientific abstracts, 8 book chapters, and more than 300 faculty lecture invites for national international conferences, and co-guide for 4 DNB theses. And her major achievement has been to set up a fetal medicine unit in Moolchand Hospital at 2005, and she is one of the pioneers in this field. So I welcome Dr. Vanna. So if Dr. Vanna is around, can we have few words from you as well, Dr. Vanna? So I think, Himanshu, can you see her that she is logged in? Not yet,
Not yet, ma'am.
Not yet. Okay, so since Dr. Vanna is not free yet, so we can move on to the academic session. And the first session is on the neurosonogram, what the imaging science, what an obstetrician should be aware of. And the speaker is Dr. Tina Verma. So I would like to invite my chairpersons and ma'am, Dr. Mala Srivastav, who everyone knows. She is a senior consultant and a professor at Gripmar, that is the Sir Gangaram Hospital, and she is a vice president elect ISOPAR 2023 to 24. So she is a current vice president, and then she has been a past president for AOGD in the year 2020 to 2021. And her area of interest is gynae oncology, gynae endoscopy surgery, and gynae robotic surgery. And she is a fellow of minimal access surgery and trained in robotic surgery at Strasbourg, France. So I welcome you, ma'am. Next slide, Himanshu. So Dr. Tripti Sharan is an associate director and senior consultant in the Department of Obs and Gynae at DLK Max Hospital, Delhi. And she has contributed regularly to the books, journals, and has several publications to her credit. And she is also a subject matter expert with Elsevier Publishing House and ex-editor of the DGF Journal and a peer reviewer. She is a member of FOGSI Sexual Medicine Committee. High-risk pregnancy, reproductive endocrinology, minimal invasive surgery, and sexual medicine are her areas of special interest. And she has been especially vocal about spreading the awareness about the teenage pregnancy, unsafe abortions, and adolescent sexuality. And she was adjudged as the Wonderful and the most inspiring gynecologist by the ET Global Youth Icon Award and Inspirational Woman, and featured by the Incredible Women of India. So she has got lots of award to the credit, and author of the Chronicle of the Gynecologist, the House of Doctors. So everybody knows she's a doctor who has who's an author for so many books, which has been quite popular, being Radha. And these are all based on those who have chance to read these books. When you read this, you will realize that you are flowing with the your MBBS or MD days in all these stories. So I welcome Dr. Tripti. Next slide, please. Himanshu. So, ma'am, Dr. Lakshmi Mantri, she is working as a senior consultant at Department of Obs and Gynecology at DLK Max Super Specialty Hospital. So, welcome you, ma'am. So now I request the chairpersons to introduce the speaker for the first session. So, Himanshu, next slide, please.
Yeah. Thank you so much, Dr. Seema. Good afternoon, everybody. Am I audible?
Yes, ma'am. Yes, ma'am.
It's my pleasure to invite Dr. Tina Verma, who is a senior consultant in fetal medicine at Dr. Doda's Diagnostic Center, Pusa Road, New Delhi. She is FNB high-risk pregnancy and perinatology from Hyderabad. She has done fellowship in obstetric scan from Chennai. She is a NT specialist from UK, London. She is a member of ISUOG London She is executive member of Genetics and Fetal Medicine Subcommittee, AOGD Delhi. She is executive member of Society of Fetal Medicine Delhi. She has also been awarded by recognition of dedicated life from IMA in 2009. Her main areas of interest are first trimester anomaly scan, fetal echocardiography, and fetal neurosonogram. She is a peer reviewer of Journal of Obs and Gynae India. She has presented an original work in fetal medicine in International Congress, and she is associated with teaching programs in Gurukul PG classes, where she takes regular ultrasound classes in pregnancy. So warm welcome, Dr. Tina.
Okay, ma'am. Thank you, ma'am.
Thank you.
Just a second. Are my slides visible?
Yeah, this is slideshow.
Yeah.
Okay, yes. So we can hear you, but we can't see you, Dr. Tina. If you can, I think your camera or you want
I
it.
just, I have to again stop share then. Just a second, ma'am. Just a second.
Yeah, now we can see you.
So this is full screen and my slides are visible, and am I
Yes.
audible? Yes. Very good afternoon to everybody here, and special thanks to AOGD Genetics and Fetal Medicine Subcommittee and Dr. Seema Thakur ma'am for giving us an opportunity to share the work and the knowledge here. And congratulations, Dr. Asmita Rathore ma'am, for taking over the academics in 2022 and 23. So first of all, what I like to say here is that ultrasound machine is an important tool in armamentarium of an obstetrician. So we have this ultrasound machine here, and we use these 4 probes to its fullest potential. And this ultrasound machine can be used to empower obstetrician and understand the fetus in a very different way. I'm sure that in ultrasound postings and in labor rooms, or whoever who is having an ultrasound machine might be doing at least a cardiac activity scan or a biparietal diameter, at least measuring the biometry of the fetus. So let us see how this one image can give maximum information in whatever a single image which we can extrapolate by seeing into the and looking into the imaging science of fetal neurosonography. For the next 30 minutes, I will be taking over I will be explaining the basic concepts of fetal brain imaging and help us to differentiate, suspect, or at least identify common CNS abnormal ultrasound appearances with the case vignettes. The incidence of CNS malformation is about 1 to 2 per 1,000 live birth, but the incidence might be higher, reaching up to 1 in 100 live births, because the incidence of intracranial abnormalities with intact neural tube is uncertain. These CNS malformations can be lethal or non-lethal. The lethal include anencephaly, rachis, Dandy-Walker malformation, and Arnold-Chiari malformation too. And why are we worried about non-lethal malformations? Because they may present as neurodevelopmental delay, intellectual disability, motor disability, or seizures. Now, this is the International Society of Ultrasound and Obs and Gynae guidelines. This is one of the pioneer journals in fetal medicine, and with an impact factor of more than 6. They have published the guidelines on CNS examination in 2 parts, part 1 and part 2, and this was released in 2020. What do they say? They give us clear guidelines and recommendations that examiners involved in screening for CNS abnormalities should be familiar with the normal CNS appearance at different gestational ages, and mainly dorsal and rhombencephalic induction defects may be visible as early as at the end of first trimester, although they are in minority but deserve special mention because they are generally very severe and are lethal. So inspired by this, we did a study in our center for the past 3-4 years and presented this in SOAG World Congress last year in October 2021. And what did we find here about the first trimester scan? We found that the incidence of structural abnormality was actually higher than incidence of Down syndrome or incidence of increased NT with adverse neonatal outcome. So we conclude that the obstetric sonologist must look beyond NT to utilize first trimester screening effectively. And this gives us an opportunity for early detection of structural abnormalities. So this is the cine loop, which we can see here. This is the appearances of the fetal brain at different gestational ages. This one is early at 12 to 13 weeks. This one is at 17 weeks, and this one is at 26 weeks. Now, if we compare, there has been a dynamic growth of the fetal brain from 13 weeks coursing to 17 weeks till 26 weeks. And we can see that the cortex has matured. There has been differentiation of the cortex and the parietes. Now, if anybody can say this is a historical image of nuchal translucency, which Kypros Nicolaides has been explaining us for the past 2 decades. This is a zoomed image of the fetal head and the thorax in the mid-sagittal section. We can see here nasal bone and we can see here NT. So this is what till now we were all asking the fetal medicine or asking the person performing the first trimester screening to see. Now, how can we extrapolate information from this single image? When we look into more details, we find that we can have a look at diencephalon here, brainstem here, fourth ventricle, which is also known as intracranial translucency, cisterna magna here, choroid plexus, and nuchal translucency. So these are the things which can be seen in a single NT image, and you are not going to take any extra time or any other extra images for documenting these. So this is an only single image. We have to document this. Now, I'll just ask you to remember one important thing in this, apart from NTMB, that is the intracranial translucency. Let us see how it is actually seen. So if we see here, this is the normal NT image. We can see 3 black lines here. Black lines in ultrasound are actually known as anechoic areas. We use the technical term as anechoic areas. So this we can see, and the middle one is the intracranial translucency. So this was introduced by Mr. Rabi Chow in 2009 in association with Kypros Nicolaides, and he said that if intracranial translucency is seen, it means that the chances of open neural tube defects are very less. The sensitivity can range from 70% to 100%. So if we compare it from the other image here, are we able to see these 3 lines here? No, we are not able to see. It means that the intracranial translucency is not well seen. In short, we say that IT is not seen. So what do we infer from it? So this is an indirect sign that there may be a problem in the spine of the fetus. So what do we do? What is the next step? The next step is to look at the direct visualization of the spine. And when we looked into the direct visualization of the spine, what did we find here? We found here an open neural tube defect, and hence we can easily explain why the intracranial translucency was obliterated. 3 basic planes of head examination are at the level of thalamus, at the level of ventricles, and at the level of cerebellum. These 3 planes I'll be repeating again and again, and the importance of these 3 planes I'll be talking throughout the lecture. These 3 are the basic planes which are to be done in any level 2 scan. So any level 2 scan has to have these 3 basic axial planes. This is not a part of neurosonogram. This is a part of basic screening examination of the head. Okay, so let us move on how these planes look in first trimester. Okay, so extrapolating these 3 planes in the first trimester, I'm here seeing the transthalamic plane, which is used for the biparietal diameter and the head circumference. This is the transventricular plane, and this is the transcerebellar plane. Again, we do a live scanning here, and just angulating the probe, the screening of the brain can be done in less than 30 seconds. Okay, So when we see the first image of the transthalamic scene, what are the things which we can see here? We have to see the ossification of the skull here. The skull is intact. There is a midline interhemispheric fissure which represents the cerebral fork separating the cerebral hemispheres. This one is the thalamus, and one more important thing which we have evolved during the last decade is the documentation of the sylvian aqueduct. So if there is aqueductal stenosis, this might be obliterated. So here we are already seeing it in 13 weeks. Moving on to the transventricular plane. If we see the transventricular plane, again, we have to document the interhemispheric fissure here. We are beautifully seeing the choroid plexus, a butterfly-shaped structure here, and the subjective evaluation of ventricles here. Okay, so when there might be sometimes a blackish area here, which is known as cavum villi interpositae, and in 50% of the cases, we might be able to see it in first trimester itself. This is the transcerebellar plane. It has its own importance. The second image which we take in the first trimester scan is of CRL. CRL must be taken by anyone who is doing the first trimester scan. And what do we see here when we compare with the other image? We see here that this one is the normal one. We see nice cranium and ossification of bones and nice intracranial contents here, which I had described previously. In here, the instant diagnosis of acrania can be made. So just in a simple CRL image, we are able to define that this baby is having acrania or exencephaly sequence. So there can be instant diagnosis of acrania exencephaly sequence just in a CRL image. Transcerebellar image, if we move on to the third plane, the transcerebellar image, again, we have to document here the interhemispheric fissure separating the two cerebral hemispheres, the thalamus here, cerebrum and the cerebellum and their peduncles. In the next image, I find some abnormality. And what is that abnormality? Here, I am not able to see this interhemispheric fissure separating the two anterior horns. There is a single monoventricle here, and the thalami appear to be fused. Holoprosencephaly. These two are lethal abnormalities and can be detected as early as 12 to 13 weeks by simple CRL and a BPD image. Moving on to another example of BPD plane. Here I'm doing the live examination of this baby, and I'm able to see that the cerebellum is not exactly in the shape what I expect to be. And I see that this is crashing over the skull. The third ventricle appears to be high riding here, and there is a defect in the posterior portion of the skull here. So what do I see? I extend my examination, I do a 3D examination and find that there is an occipital encephalocele. Whenever one sees an occipital encephalocele, we have to rule out a very important syndromic association. We see the kidneys here, and we count the fingers. We see the association with polydactyly. And if there is polydactyly with occipital encephalocele or hydronephrosis with occipital encephalocele, probably we are dealing with Meckel-Gruber syndrome. Again, is a lethal abnormality. This is a classical example of an encephalocele. Here we can see the defect that the skull is not formed here, and the encephalocele is seen floating in the amniotic fluid. Now, posterior fossa. What is posterior fossa? If we see this image, these two are the transventricular plane and the transthalamic plane, and there is only one plane which images the infratentorial portion of the skull. This includes the cerebellum. Okay, so this is known as posterior fossa or infratentorial plane, and transcerebellar plane is the only plane which actually looks into the details of it. This again has been extrapolated into the first trimester, and here I see that there is some posterior fossa abnormality. The posterior fossa is bigger, anechoic, then we do the scan further, and we find that in 16th week that this is a Blake spout cyst, and this was another image showing a Dandy Walker malformation. So an instant diagnosis should not be made in first trimester about the posterior fossa. All the abnormalities should be followed up till 16 or 17 weeks at least to see how the cerebellum and the worms are developed. First trimester neurosonogram has been introduced by Nicola Volpe in this year itself, and it was released in UOG, and it includes volume probe, the 3D dimensional probe, TVS probe, and it includes the multiplanar imaging and we look into the details of the choroid plexus and fourth ventricle and the cerebellum and the vermis. And hence this has been introduced, and we'll be looking more forward how it gives information to us. Moving on to the level 2 scan. Again, I'll be reiterating three basic planes, only three basic planes: transventricular, transthalamic, and transcerebellar, and you will be notifying most of the abnormalities, diagnosing most of the abnormalities here if you do a pattern recognition of what normal is. So any deviation from the normal, it means that we are dealing with some abnormality, or we are at least suspecting some abnormality. So how do these planes look at 17 weeks? Here we can see transthalamic plane, or the BPD plane to be more commonly used, transventricular plane, transcerebellar plane at 22 weeks, and this one is again at 17 weeks. So how do we remember these names? Simple. If we are seeing the thalamus here, this is the transthalamic plane. If we are looking at the ventricles here, this is the transventricular plane. And if we are looking at the posterior fossa and the cerebellum here, this is the transcerebellar plane. So just remember transthalamic, transventricular, and transcerebellar plane. Ask for these images. Even if you are sending the patient for a level 2, ask and see for these images by yourself. If you are doing it in your ultrasound machine, try to perform these scans and try to image these thing and just identify how we are going to look at the planes. Now this is the transthalamic plane, or the BPD plane. Look at the integrity of the skull, ossification of the skull, look at the thalamus. One important thing which I like you to see is just add two more things. This rectangular box, look for this rectangular box here. This is known as cavum septum pellucidum. What is cavum septum pellucidum? Cavum septum pellucidum is a fluid filled space which is lined laterally by medial border of the lateral ventricles. This area is the anterior horn of the lateral ventricles. All the three in combination is known as anterior complex. So look for anterior complex, and if you do not find the anterior complex to be normal, or if there is any deviation in the anterior complex, then it might be that we are dealing with non-visualization of cavum septum pellucidum. So what is the significance of non-visualization of cavum septum pellucidum? This is an indirect marker of absence of corpus callosum, most commonly known as agenesis of corpus callosum. We do an extended neurosonogram, look at the corpus callosum. If by chance the corpus callosum is seen and the cavum septum pellucidum is not seen, probably we are looking into other differentials like septo-optic dysplasia, absence ENSP, or lobar holoprosencephaly. The fourth important thing which I like to have your attention is Sylvian fissure. This Sylvian fissure is a dynamic process, starts between 22 weeks and ends till 32 weeks. And why is it important? Because this is an important marker to identify disorders of neuronal migration. So if you are not able to see this image after 22 weeks, we might be dealing with migrational disorders. So 4 things to remember: interhemispheric fissure, interrupted by cavum septum pellucidum, thalamus, and Sylvian fissure. Transventricular plane, 2 most important things to be seen. Look at the curvature and the shape of the lateral ventricle. Look at the choroid plexus here. Here again, we are documenting the cavum septum pellucidum. The other important significance is measuring of the lateral ventricles. How do we measure lateral ventricles? Here, 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 where? So ASWOG has again standardized the procedure. Locate the parieto-occipital fissure here. This is the parieto-occipital fissure, like a shallow groove here, more prominent at 20 to 22 weeks. Locate it and then try to measure the ventricle at this level. The margins will be from in to in, like this. Till here, we are going to measure the lateral ventricle. And then if it is more than 10 mm, Probably we are dealing with mild ventriculomegaly, and it ranges up from mild to moderate to severe ventriculomegaly. One more thing which is important here to note is the posterior complex. Again, we have to see here that there is interhemispheric fissure and there is parieto-occipital fissure. The third and the only plane which looks at the infratentorial portion of the skull is the transcerebellar plane. So if we look at the transcerebellar plane, we see here that the skull is intact. We see the interhemispheric pressure, interhemispheric fissure here, the contour of the cerebellum, vermis, cisterna magna, and the nuchal fold thickness. So why contour of the cerebellum is important? Because sometimes cerebellum herniates into the spinal canal, and we can find that there might be an Arnold-Chiari malformation, or the vermis may be absent and both the cerebral hemisphere may be fused together, leading to rhomboencephalosynapses. Echogenicity is important. Why? Because if there is an echogenic area here or here, there might be a cerebellar hemorrhage. Fourth ventricle shape is sometimes seen, and if there is an altered shape in the fourth ventricle, probably we are dealing with Vermian agenesis. Again, here we have to look for the cavum septum pellucidum to ensure that we are not leaving a part of corpus callosum which is unseen here. Central nervous system examination is not complete without the evaluation of spine. The spine is evaluated in 3 planes: sagittal, coronal, and axial planes. What do we see in grayscale imaging? We see the intactness of skin. We see all the ossification centers. There are 3 ossification centers, and we see at every level the shape of the ossification centers is different. The shape of the spinal canal is different. Hence, we have to ensure that the spine is absolutely normal. At the end of the brain and the spine evaluation, we have to ask ourselves, was the assessment satisfactory? Is more information required from additional imaging? Is referral needed for neurogenetics and pediatric neurology? Is there a need for invasive testing? And is there a need for follow-up examination? So ISUOC has given us clear indications of fetal neurosonography. And what do they say? They say that if suspicion of a brain or spinal abnormality is raised during the obstetric ultrasound screening examination, which already we are doing, then the woman should undergo the targeted fetal neurosonography. The other indications of fetal neurosonography include abnormal NT scan, family history of spinal malformation, fetuses with congenital heart disease, monochorionic twins, suspected infections, exposure to teratogens, and to complete the list, chromosomal microarray findings of unknown significance. So what does extended neurosonography mean? This is a multiplanar approach. Now, in level 2, we saw 3 basic planes. In extended neurosonography, we add 7 more planes. So what are these 7 more planes? We see the fetus in coronal sections from front to posterior. And there are 4 planes: transfrontal, caudate, thalamic, and cerebellar. Every plane has its significance. In the mid-sagittal one, in the parasagittal one, we say there are 1 mid-sagittal plane and 2 right and left parasagittal, paramedial sagittal planes. So how do we perform the coronal scanning? From front to posterior, if you see the Cinello, from front to posterior, I am just rotating and sliding my probe from anterior to posterior portion and looking into the final details. Interhemispheric fissure, caudate nucleus, corpus callosum, CSP, anterior horns, even the optic chiasma and the thalamus can be seen very clearly in coronal planes. What do we do in sagittal planing? From coronal, we go to the bank, middle of the fetus in the profile imaging and try to locate the lateral ventricles here, corpus callosum, and vermis. So one important thing which I like you to have emphasis on is the mid-sagittal plane. Why is mid-sagittal plane important? Because it is the only plane which will be documenting the corpus callosum in its entirety and vermis. The corpus callosum has 4 parts. An absence of even one of the parts leads to diagnosis of partial agenesis of corpus callosum. So what are these 4 parts from anterior to posterior? Anterior is rostrum, followed by genu, trunk, and the splenium is the most posterior part of the corpus callosum. So hence, this is important that we see the corpus callosum in its entirety in the mid-sagittal plane. There are structures which are worthwhile to be noted in mid-sagittal plane, like fornix, tegmentum, pons, vermis, fourth ventricle, etc. Here is the cavum septum pellucidum, corpus callosum, fornix, vermis, and fourth ventricle. Sometimes we need help of Dopplers to see the vascular supply, pericallosal artery. Let us see how we diagnosed important malformations in planes. Transthalamic plane, BPD plane. Again, 4 important things to be seen: interhemispheric fissure, anterior complex, and Sylvian fissure. Can anybody tell what am I seeing here? I'm seeing here that the brain is floating into the amniotic fluid. This is acrania. Again here, transthalamic plane, normal transthalamic plane. Here, I'm seeing that the posterior skull is deficient and there is a space occupying lesion here. Intracranial contents are herniating into it. This is an encephalocele. This one is an interesting one. I'd like to bring your attention here in the anterior complex. Now see, this is the normal one, and here I'm finding that there is no interhemispheric fissure. So here comes the importance of interhemispheric fissure. If you notice that the interhemispheric fissure is absent, probably we are dealing with holoprosencephaly. I confirm it on the coronal section. See, this is the normal one. I am seeing the interhemispheric fissure here, but in this, there is an absence of interhemispheric fissure and fused thalamus. This is holoprosencephaly. Transventricular plane, 2 important things to be noted: cavum septum pellucidum and the ventricular width. If I see ventricular megaly is not a diagnosis, many cases and many pathologies present with indirect signs of ventricular megaly. There can be septations inside. We can see periventricular heterotopias. Here, this is the dangling choroid plexus. What do you mean by dangling choroid plexus? When there is severe hydrocephaly, we see that the choroid plexus is hanging like an earring. This is known as dangling choroid plexus. Another important thing in transventricular plane, which I referred previously, was the shape of the lateral ventricle. Now here, if you see the shape of the lateral ventricle, it is teardrop in shape. So what is this? Another thing which we have to look here is the cavum septum pellucidum. Are you able to see the cavum septum pellucidum here? No. It means that we are dealing with something with corpus callosum. So I confirm it on extended neurosonography, and what do I find here? I should have seen the corpus callosum like this, but I am not able to see the corpus callosum. So probably we are dealing with agenesis of corpus callosum. I confirm it in the Doppler scanning. I am not able to see the pericallosal artery. The course of the pericallosal artery should have been like this, posterior part, but I'm not seeing that here. So we confirm that this is a corpus callosum agenesis. Rarer abnormalities can be detected, like coma of corpus callosum. This baby is absolutely fine, and it's of 2 years of age. Normal variants, if isolated, choroid plexus cyst is a normal variant. Look at the echogenicity of the choroid plexus. If you find a cyst here, you are dealing with choroid plexus cyst. Transcerebellar plane, the only plane which shows the infratentorial portion. What do we see here? First of all, we have to see the contour and the shape. Let us see the contour and the shape here of the cerebellum. Do we find it normal? No. We find that there is, in this clip, we find that this cerebellum appears to be herniating into the spinal canal. And when does this happen? This happens when there is a leakage of CSF into the spinal canal, from the spinal canal. It means that there has to be some abnormality in the spine. We searched for it, and we found that there is an open neural tube defect. So 97% of the cases with an open neural tube defect, and intracranial signs will be present. This is an Arnold-Chiari tube malformation showing the intracranial signs with an open neural tube defect. Another important thing why I am discussing in the cerebellar plane is the Dandy-Walker malformation. Here you can see that the cerebellum is splayed, vermis is absent. I confirm it. This is another case. You might have a posterior fossa cyst, and then I confirm it in the multiplanar imaging and find that there is an enlarged cisterna magna with absent vermis, leading to the diagnosis of Dandy-Walker malformation. I confirm it in the sagittal plane, and what do I see here? I should have seen the vermis here very nicely of this shape. Do I see it here? No, I don't see it here. This portion of the vermis is absent. So there is some vermian dysgenesis. There is partial agenesis of corpus callosum. Probably I'm dealing with Dandy Walker malformation, which is a lethal abnormality. Similar image of Dandy Walker you might see again here, but in some image you may find that the vermis is there. Sometimes you may feel that the cerebellum is played and there is no vermis. What do I do now? I confirm it on the sagittal plane, extended neurosonography, and I find that the vermis is present, but there is a small anechoic area here, which might be an arachnoid cyst or a Blake's pouch cyst. And mind you, the prognosis of Blake's pouch and arachnoid cyst is very good as compared to Dandy Walker malformation. Hence, extended neurosonography helps in prognosticating the abnormalities. Cerebellar hyperplasia can be diagnosed by measuring the cerebellum and looking into the other features of the ventricles and interhemispheric fissure. Now, this is an interesting case. This was a case which was referred and was showing a normal level 2 scan elsewhere. Somehow, our geneticist thought that no, because the previous baby was having a binder's facies and the mother was on mechanical valve replacement on warfarin, high doses of warfarin, she referred for level 2 scan again, and I found that there is binder's facies. What is binder's facies? Nasomaxillary hypoplasia. So this is flat face, and when I look into the brain, what do I see here? I find here that the echogenicity of the cerebellum is abnormal. So probably this is an old intracerebellar hemorrhage which has occurred. This was a stigmata of warfarin embryopathy. This case was, again, if you look at the face, there is severe retinogathia, Piri-Robin sequence. Looking into the brain, we find there is a variant of holoprosencephaly, centellin-cephaly. Now, how Doppler has changed our diagnosis. Sometimes what happens is everything is fine. You may find that the axial plane and the coronal and sagittal planes are absolutely normal, or maybe some deviation. But adding the Doppler gives us an additional information. Now, this patient was referred as cardiomegaly, and the cause was unknown. There was no cause in baby, no cause in placenta. There was no hydrops, nothing else, only cardiomegaly. When I put a color Doppler, we just screened and we saw an anechoic tubular structure. Putting the color Doppler showed there was ectasia of vein of Galen malformation. Again, this patient was referred as intracranial teratoma. Putting the Doppler, we find that the vascularity was nil, which should have been in teratoma, and the size was decreasing. This came out to be intracranial hemorrhage. Third one was interesting. This is a recent case which was referred as corpus callosum dysgenesis at 29 weeks. And what was found was that at 20 weeks, it was done by a fetal medicine person, and the corpus callosum was probably documented. But now at 29 weeks, when she came, the corpus callosum was not to be seen. The anterior complex was abnormal. So what did we do? They did an external neurosonography and saw that there was a corpus callosum dysgenesis. But additional finding, what was revealed was when I put a Doppler here, I see that there is a vascular malformation in the circle of Willis with an arterial flow. This is not an AVM. This was purely arterial aneurysm. So this was a rare finding here, which is aneurysm of circle of Willis. Spine again, this was already explained how to look at the conus medullaris, lower portion of conus medullaris. It generally lies at the level of L2 and L3. If it is lying lower, it means that we are dealing with the third cord, or if it is attached to the posterior portion, we are dealing with the third cord. Shape of the spine, open neural tube defect, and again, shape of the vertebral body, kyphoscoliosis, hemivertebrae, butterfly vertebrae, all can be diagnosed very nicely in extended neurosonography. Open neural tube defect or meningomyelocele can be seen at any level, at cervical, thoracic, lumbar, lumbosacral. It can be easily documented once we try to look for the cause. This is one of the rarer malformation which is highly lethal, known as spinal racheschisis. What happens is the spine is not closed. The entire spine is opened like a zip. And this again is a lethal malformation. So to conclude, it is always that the mind sees. The eyes are merely receptors that translate light rays into the signals to the brain. And when the mind knows, the eyes see. This is the power of observation. And I'll request my obstetrician friends who are into ultrasound to know what pattern recognition means and know the importance of pattern recognition of the ultrasound images. The take-home messages from my talk is that first trimester scan is not only for NT, its potential should be fully extracted by looking for other major structural abnormalities. Fetal brain should be screened in at least 3 planes: transthalamic, transventricular, transcerebellar. ISWORK has provided clear indications for fetal neurosonography and extended neurosonogram. It must be done by an expert. Fetal MRI may be performed only after neurosonogram and if requested by an expert. Thank you.
Thanks, Dr. Tina. It was really a very exhaustive and informative scientific derivation that you have made. And you have made look neurosonogram very simplified. But it's a work of an expertise. And as Dr. Seema said, that incidence of CNS abnormalities is almost as high as 1%. So ultrasound we have been seeing for 30 years as the main modality to help diagnose fetal CNS abnormalities. And first trimester scan is not only NT-NB, as you have rightly said. Detailed evaluation of the fetal CNS is possible, but it requires specific and expertise with sophisticated, maybe sometimes ultrasound machine as well. This type of examination at times is complemented in cases, especially if there is an indication for CNS abnormalities, as you have rightly said in your lecture. Most of the CNS abnormalities can be nicely detected during anomaly scan or third trimester scan, but there is an advantage. And as you already said, that you can have an early neurosound scan between 14 to 16 weeks, so that time the bones are thin and brain may be evaluated from all angles. So, Dr. Tina, it was a very nice deliberation, and I'm sure all our obstetric friends who are doing anomaly scan or NT scan, they understand that first trimester scan is not only NT-NB, they can be extrapolated to many, many cases which can alert us, and we can refer those cases for neurosonogram. Thanks, Dr. Tina.
Thank you, ma'am. Thank you, ma'am.
Dr. Vandana, have you joined? Yeah, Dr. Vandana, I could see that you have joined. Okay, so wonderful presentation, Dr. Tina. From the obstetrician perspective, which I feel important is that, there are two basic things which an obstetrician should know. These are, one is that the counseling regarding the prognosis, that whether the pregnancy has to continue or whether this has to be terminated. So that message should be very clear for them, that, which are the abnormalities which you feel that this is 100% lethal, and which are the abnormalities which you feel that you are not very clear and you need further follow-up scans. Because many times in the first trimester, I keep, seeing the obliterated, the IT. And in those situations, the patient goes for one scan, another scan. So my message would be that in these situations, probably adding an alpha fetoprotein, because as you know that these days we have first trimester quadruple, first trimester penta screen. So many a times that will also give a clue. So it's how to handle, these advances are there, but at the same time, our clinical expertise has also to evolve so as to manage the patients, because, scanning, and many a times we realize that these are again like variation of uncertain significance kind of things. So these we should know that, how to handle them. So the counseling regarding prognosis should be very clear. And also when all these pregnancies are aborted, then you need the further autopsy, genetic testing, because from the parents' perspective, it is important that the recurrence risk should be known. So thank you, everyone.
Yes, ma'am, very rightly said, and we will be discussing this in the panel.
Yeah. So Vanna, would you like to, you have joined, so your inputs, because you have been dealing with these since ages, I know, since I know you. So it's more than 22, 23 years.
Yeah, I think CNS anomalies are a big part of the problems that we endeavor to pick up in the pregnancy. And now that we have the 11 to 14 week scan, we can start looking at our spina bifida, the open defects, even early on. And we should not be missing any acranias. And the 18 to 20 week scan, where we are looking at our transaxial views, we should be very careful in documenting the standard planes when we, for medical legal purposes as well. And we should all know that most of the CNS anomalies, or at least 50% of them, can appear later. And so even in the third trimester, you cannot give up your guard, and you should be looking at the brain even later in the pregnancy so that you don't miss something serious even later on, especially in the perspective of the recently changed MTP laws.
So any, any suggestions when to refer for neurosonogram? Some
I would say like the general screening we do for everybody. So every patient deserves in the 20-week scan at least the anomaly scan, at least the transventricular plane and the transthalamic and the transcerebellar planes, which we do as a standard view. But once you have seen something in the screening, or you have a family history of a disorder, or the lady has suffered from a previous baby who has had a problem related to the CNS, or if somebody else has reported an abnormal fetal echo, or an amnio has been done where a microarray has come back as abnormal, or if it's a complicated twins, sometimes mono twins. So some of these are indications where you would like to do an extended neurosonogram, because it takes much more time, and an extended neurosonogram will involve doing much more additional views and more time consuming. So the obstetrician should be aware of, and once you have done an extended sonogram, then an adjunct MRI would be used. I'm sure the next speakers will be touching on those lines.
So I think with this, Dr. Tripti is not around. Dr. Tripti, so I think she's not around. So with this, we conclude the session. Now we move on to the next session. And I would like Dr. Tina to introduce the chairpersons.
Yes, ma'am. So we are moving ahead.
Yeah.
We are moving ahead with the session 2 of basics of fetal neurosonogram and fetal MRI for obstetricians. And here, slides are not moving.
Yeah, we can see, Dr. Tina, we can see your slides.
It's an honor for me to introduce Dr. Poonam Khera. She's the Director and Senior Consultant in Obs and Gynae Department of BLK Hospital, and she's also a DNB Coordinator. She has her fellowships in MNAMS, FICMCH, and FICOG. She's a member of AOGD, FOGSI, and NARCHI, and also Indian Association of Gynae Endoscopy. She has awards. She has recently got an award of Woman of Inspiration in 2021 from BLK Max, and is an inspiring gynecologist in North India, awarded by Times Group in 2018. She had many publications in national journals and has presented paper presentations in FIGO 2018. Her main interest is in gynae laparoscopy surgeries and high-risk obstetrics. Our next chairperson is Dr. Nitish Sharma. He is MBBS and DNB radio diagnosis. He is a distinguished fetal medicine consultant working in Sir Gangaram Hospital since 12 years. He's trained in fetal echo and fetal intervention procedures, and he has keen interest in various interventional procedures. He is affiliated to SFM India, Indian Radiological Society, IFUMB, and Indian Society of Pediatric Radiology. Our third chairperson is Dr. Swapnil Seth. He is Associate Consultant in Department of Radiology, Sir Gangaram Hospital, New Delhi, and he has a special interest in dedicated musculoskeletal system. He also has an interest in neurology, hepatobiliary, and fetal imaging. He has been an invited faculty in various national CMEs, and an invited faculty as a panelist in various CMEs. He has presented paper and posters in multiple CMEs and has written a book chapter on in Index Journal. He's a member of Imaging Today's Scientific Committee member and is active in resident teaching programs. He's also a member of Indian Radiology Society. Dr. Poonam ma'am will introduce Dr. Doda.
Yeah. Hi, everyone. It's my honor to introduce Dr. S.S. Doda, founder director, Doda Diagnostic and Healthcare. And Dr. Doda is an eminent radiologist and has vast experience of more than 40 years. He started first third generation whole body CT of the country at Sir Gangaram Hospital, New Delhi in January 1983. He worked as a senior consultant in Divanchand Agarwal Center also from 1987 to 2003. At that time, he was DNB guide also for 10 years till 2003. He received many fellowships from 1984 to 1999 from UK and USA. From UK, he received a fellowship in CT, and from USA, he received a fellowship in MRI and colored Doppler from Thomas Jefferson University, Philadelphia in 1998. He received many awards and main award is highest academic award in Indian radiology that he received the Dr. J.C. Bose Memorial Oration in 1999. And next is he has been honorary radiologist to the former President of India, Shri Pranav Mukherjee. Recently, Dr. Doda has received Lifetime Achievement Award 2022, March 2022 by IR, Indian Radiological and Imaging Association in 74th Annual Congress in March 2022 in Bangalore. So this is the latest lifetime achievement. His topic for presentation is a discussion about the fetal MRI, when to order and what to expect. This is very important topic for all of us, especially for obstetrician to decide further, and counseling is important. That also helps after seeing the fetal MRI, and it's for us to discuss about the prognosis with the family. So topic for Dr. Doda is fetal MRI.
Thank you very much, everybody. A very good evening to all of you. And first of all, I would like to take this opportunity to thank the Genetics and Fetal Medicine Subcommittee of AOGD Delhi chapter for giving this opportunity to us to be present amongst you and to share our experiences and to learn from all of you through this interaction. Well, I'm going to speak about fetal MRI as an imaging tool. There is absolutely no doubt that fetal MRI is relatively less often used when we are evaluating the fetal anatomy. One of the most important things to know is that when to order the fetal MR. And since you have seen such wonderful pictures from Dr. Tina, and it seems that probably nothing would be left out of sight as regard to the details of the fetal anatomy, and especially the brain and spine. At the same time, we do fetal MRI sometimes, and the best results of MRI to depict the fetal anatomy are usually towards the late second trimester and in the third trimester. There is also absolutely no doubt that you can do an MRI of the fetus at any time in the pregnancy. And generally speaking, there are no harmful effects of MRI, although it is advisable to do the things when most of the organs are fully evolved, and that is between 26 and 32 weeks. And before we go on to the MR pictures of fetus, one of the basic thing for all of you, especially from the obstetrics side, to understand is that there are two sets of basic images in MR, and they are basically T1 and T2 weighted images. And one of the wonderful thing about MR as compared to CT or as compared to X-ray or as compared to ultrasound is that you can exploit so many parameters in different manners. And the T1 weighted pictures usually show the water or any fluid as dark, and T2 weighted sequences usually show the water or hydration or edema as white. The T2 weighted images usually show the anatomy nicely, whereas T1 weighted images show certain abnormalities, especially, for example, the hemorrhage, which appears white, the calcification, which appears dark, and the fat, which also appears bright on both T1 and T2. So these parameters can further be exploited by so many variations of the sequences, and that makes MR extremely useful in practically all spheres of areas where it is used. There is absolutely no doubt that ultrasound remains the primary screening modality. But as everything in life has certain limitations, ultrasound is also limited by relatively a poor penetration, especially when you have a large, the abdomen size of a woman who is pregnant, and especially towards the full term. It's a very, very large area. Sometimes you can have problems while doing ultrasound, especially when you have, let's say, ossified skull, which is fully developed, and it is stuck lower down in the pelvis, and it is difficult to negotiate through and look for that kind of detail of anatomy which you want to. When the fluid is less, the amniotic fluid is less, again, there are problems because all the fetal parts are jam-packed. It's difficult to separate those parts. And when the fetal position, like, for example, when you have relatively late pregnancy and the spine is towards posterior side, so, I mean, there are so many things, when probably, see, in imaging, in every modality, sometimes you want to be a little more confident. Sometimes you are not very comfortable, and you want the help of other imaging modality. And that we usually do in other types of cases also. As I was telling you, MR has certain advantages. It has got a very superior contrast resolution. It can show the CNS structures very, very beautifully. And we all know that MRI is the modality for the normal brain or spine evaluation in the general population. It has got a large field of view. And the other big advantage of MR is that it shows things in a multiplanar manner. You can do axials, you can do coronals, you can do sagittal. So there, you get a lot of advantage compared to a few other imaging modalities. And of course, you don't have any harmful effect. You don't have any ionizing radiation or so in MR. And there is no doubt that MR helps, like in difficult cases, or like where you are not very comfortable, you want to help, you want to take the help of second imaging modality. There it helps to confirm diagnosis or offer alternative diagnosis. It identifies additional abnormalities, and that all helps in better patient counseling and management. And it does act as a problem solver in such situations. MR has a role right from top to bottom, right from CNS, neck, chest, abdomen, lung hypoplasia, renal abnormalities, genitourinary abnormalities, and spine, of course. Now we have limited experience. I have no doubt. I should say that in the last 5-6 years or so, we have seen about 43 cases. The list is here, and out of these cases, in whatever way they came to us, whether the ultrasound was done earlier, maybe outside, or we did, and we sort of recommended MR, and we did it, or these patients came for an MR first, and then we also did an ultrasound, which I will be showing. Rather than showing you the complete spectrum in a theoretical manner, which probably you people know better than us, I would like to highlight that about the cases which we came across during these 5 years or so. First of all, normal anatomy. As you can see, MR shows these things so beautifully. The complete fetus, right from top to bottom, you can see most of the things very, very nicely, whether it is face or brain or spine or abdomen or any of these things. For example, let's say this is just a comparison with ultrasound. There is no doubt that Dr. Tina showed, or we all see these the anatomy of the brain so nicely on ultrasound, but MR also shows similar details of brain on evaluation. This is a cross section of the chest. This shows the lungs so nicely as echogenic, things, both sides of the heart, very nicely seen here. Now coming to some of the anomalies visualized on MR. Fetal MR of the CNS is particularly helpful once you have established there is a ventriculomegaly. You want to see the etiology, whether it's corpus callosal dysgenesis or agenesis, and certain posterior fossa abnormalities, which some of them have been shown by Dr. Tina. And of course, there are myelination and migration abnormalities where there is ectopic cortex, or there is pachygyria or polymicrogyria, and those areas perhaps MR can be really very helpful. There is no doubt that ultrasound is evolving, and I'm sure that time is not very far that ultrasound will also show it very nicely with increasing experience. The other thing is hemorrhage or ischemia. You can exploit the hemorrhage at its various stages, which I'll be showing you in 1 or 2 cases. Now, this is a case which is showing dilatation of the ventricle. Of course, partly there is some brain parenchymal loss also, which is making this CSF signal intensity area, which is extending right up to the periphery. It's almost geographical manner in the posterior and superior portion of the brain parenchyma. So there is some brain parenchymal loss with dilatation of the ventricles. And in the same case, of course, the ultrasound was done, and this ultrasound has already been shown by Dr. Tina just now also. You can see these cystic areas also showing some septa and ectopic cortex, and there was dysgenesis of corpus callosum in this case. Another case with similar findings, you can see the ventricles are dilated, and you can see teardrop kind of occipital horns here, and the ventricles are apart, and you are not able to see the corpus callosum here. So this is a classical appearance of dysgenesis of corpus callosum. And the same case was shown by Dr. Tina, where we picked up also, in addition to dysgenesis of corpus callosum, this was a vessel over there, an arterial vessel showing arterial waveform, possibly an aneurysm of the circle of Willis. There is absolutely no doubt that we don't have the follow-up of this case, but this was an additional finding which was seen on MR. So Just a minute, next. Next second. What has happened here? This is not going up. ये देखो जरा आगे नहीं जा रहा है।
I think sir stop share करके एक बार फिर से try कर लीजिए sir.
हाँ वो मेरे ख्याल से कहीं वो आया है कहीं। हाँ next.
Go left and right.
हाँ okay ठीक है. All right. So this is another case where ultrasound was done outside, and the patient was thought to be having hydrocephalus, which obviously it is there, and patient came for a second opinion. And in addition to that, the hydrocephalus, where the ventricles are clearly dilated, we found something in the cerebellar area, and we thought this was some kind of space occupying lesion. And whenever you find such a thing over there, you immediately suspect whether this is hemorrhage or not. And we convinced the patient to get an MRI done. And since MRI shows the hemorrhage in various forms, both acute and chronic, and right there also we can see the same kind of lesion over there, but having a dark signal on T2 weighted images. So in addition to that, we could see additional areas of similar thing, and then we had no doubt that this was a subdural hemorrhage in the temporal region, and this was a hemorrhage in the cerebellar region. And this was a patient of my maternal wall replacement, and patient was on warfarin and had subdural hematoma as well as cerebellar bleed. This patient, we followed this patient, and this patient was delivered normally, and the child is normal so far. Now, coming to other areas, the neck masses, we all know about cystic hygroma and lung problems. We know that cystic adenomatoid malformation, sequestration, we have been seeing all these things in various forms on ultrasound very, very effectively. There is no doubt about this. And sometimes there are problems. I'll show you in one or two cases. One of the additional advantage of MRI, we have done that we have been able to calculate the lung volume also. And there are various ways that you can, compare it with the normal lung volume and thereby diagnose the hypoplasia. You have seen that I had shown you a slide where the lung was relatively brighter looking, but when you have a relatively low signal fetal lungs, then you suspect pulmonary hypoplasia. And you can also compare the signal intensity of the lung with the liver, and there are certain ratios which can help you reach a diagnosis of hypoplasia, especially after 26 weeks. Now, coming to one of the case, 34 weeks, 2 days, she came to us for the evaluation where the stomach bubble was seen in the chest at the level of heart, as you can see right here. You can see the serial sections, and then the cross section, stomach bubble is seen here, and the heart is seen here. And you suspect whether it is a hernia or eventration. And we did an MR in this particular case. These are the axial pictures as we have seen on ultrasound also. Again, you see that the heart is at the same level as the stomach bubble is there. But then you can also do sagittals, and you can also do coronals, and you find that here the normal lung is seen very nicely on the left side, and that's the heart over there. And that's an area where there is abnormality. But the beautiful thing here is that you very nicely see the diaphragm here. The stomach has gone up quite a bit and up to a mid chest level, and the diaphragm is intact. So this leaves no doubt that there is eventration actually, and not the herniation. Now, compared to this is another case, of course, done at 37 weeks. And you can see here again, the heart is seen here, and the stomach bubble is also seen here and the same level. And when you are doing MR, of course, you see plenty of bubble loops over there in the chest at the level of heart, and the lung is seen on the opposite side, and lung is completely compressed on this side, very nicely seen here. But when you go to the longitudinal planes, that is sagittal or coronal planes, you find practically the entire chest is occupied by the bowel loops. So there is absolutely no doubt that this is, you don't see the shadow of the diaphragm anywhere. So this is definitely diaphragmatic hernia. And in these cases, in the same case, like for example, you can take the lung volume using certain parameters in the machine, the MR machine, and thereby you can calculate the lung volume. For example, here was 22.8 cc here, and you can compare with the normal charts as you do with the BPD, etc. So now coming down to abdomen, let's see one of the common areas where the abnormalities occur, and that is the urinary and genitourinary system. So this was a 19 weeks, 6 days patient, pregnant female. And you can see here that this patient had a bifid system in the left kidney, and this is the dilated ureter, which is going down, and this is going quite lower down in the lower pelvis, and it's coming rather almost to the, the surface of the skin. So this indicates that most likely there is ectopic opening of the upper moiety with a bifid system. This is the axial of the same patient, and you can see that this is dilated pelvis, and then the ureter is crossing and coming on that, on the other side. And the other kidney is normal here. This is the other kidney, which is normal here. The same patient, of course, we took the patient later on for ultrasound, and we could see these things nicely, knowing all those things. This is the cranial side here. This is the kidney, and this is the dilated ureter going down in the pelvis. The same here, lower down in the pelvis. And this is upside down. The cranial side is here, and the ureter is going down over here. And this was the lower tip of the ureter, quite lower down in the pelvis. But MRI has shown nicely in this case the ectopic opening of the ureter. Another case, 19 weeks, 5 days, bilateral hydronephrosis and dilated ureters. And on both the sides, we thought that there was duplex system, and you can see here, this side kidney showing hydronephrosis. On the other side, the kidney is showing hydronephrosis. There appears to be a duplex system here, duplex system on this side also. And lower down also, we can follow the ureters here on both sides. The same thing seen in axials. You can see here that both the kidneys are showing dilatation here. Both the kidneys are hydronephrotic. This one is hydronephrotic here, and this one is hydronephrotic here. Same patient taken for ultrasound also. Again, that is also showing nicely the presence of bilateral hydronephrosis here, bifid systems here, and dilated ureter seen on one side very, very nicely. So in this kind of situation, sometimes you need the help of other imaging modality to raise your level of confidence, in spite of knowing that, yes, you probably are correct. And there we find that, yes, we have a nice interaction with, between the MRI and fetal ultrasound people. Another patient, 18 weeks, 1 day, ultrasound visualized echogenic enlarged left kidney with multiple cysts, and MRI shows the same thing here. You can see this one kidney is showing a little bit of prominence of renal pelvis, and this kidney is enlarged. It's showing multiple cystic areas here. So this was a multicystic dysplastic kidney. The same here. This is multicystic dysplastic kidney here, and this is on the other side, little bit of dilatation of renal pelvis. The same patients, of course, ultrasound pictures we took later on after MR, since patient had come from outside and it was already labeled as multicystic dysplastic kidney, but wanted a second opinion. And you can see dysplastic large kidney over there. This was a patient having diamniotic monochorionic twin pregnancy at 18 weeks, 3 days. And we had done an ultrasound on 9th of February 21. And we labeled it as twin transfusion. And of course, with the discordance in the growth of the other baby. The patient went to All India Institute and underwent the post RFA on 15th of February of one of the twin. And patient came to us later on for an MR sent by All India Institute. And of course, in these cases, you want to know the well-being of the normal baby, and you want to rule out, any residual brain parenchymal abnormality in the twin fetus. Of course, you have various classifications and all that, which are, of course, better known to you, and you practice those things every day. So this was it. The same case showing the normal twin here, and the smaller one being the dead fetus. Placenta is an important area to evaluate on MRI. And of course, we all know the ultrasound features of whether you do transvaginal ultrasound, whether you do transabdominal high resolution ultrasound, to the features of the placenta accreta, when you loss of the chorionic plate, or you see vessels crossing into the myometrium, and the bands through the placenta. MRI is definitely adds to the level of confidence sometimes when you are not sure. For example, in this particular case, 16 weeks of pregnancy came to us from Lady Harding, and they suspected that there were large vascular channels in the chorionic plate and the posterior placenta, most of these being placenta previas. And you can see here the vessels are crossing across into the myometrium very, very clearly, right up to the periphery. In fact, there is a loss of chorionic plate also. The same here in the same patient. So placenta accreta, which it was proved. And the same patient, we did an ultrasound after MR, and we also found that ultrasound suspicion was correct, and vessels are seen over there. So in conclusion, basically, we all know that ISUOG guidelines for the performance and reporting of the fetal MRI state that MRI should be performed only after and to complement a neurosonographic examination, particularly in the brain, if this is considered to be indicated by the trained operator. This not only applies to neurosonography, but to everything in the fetus. And especially with the current technology of ultrasound, machines, we are able to get wonderful, exquisite details. And there are very few limited cases where, after having gone through an experienced operator, the MRI is required in about 7 to 15 cases of abnormalities, especially neurosonography. So thank you very much once again to all of you for being patient listeners, and thank you very much for inviting me to this program. Thank you.
So thank you, sir, for such an excellent overview of the fetal MRI, the indications. You have already, widened our thinking that whether, a fetal MRI or what is the, what are the indications. And probably after hearing your lecture, I feel that there are more indications rather than, the traditional. So Dr. Swapnil, would you like to have, add something to the sir's? I would like you to add some.
Yes, ma'am. So Dr. Doda has very nicely depicted almost all common anomalies on the MR that we get. But having said that, so definitely fetal MRI is one of the underutilized modality for the fetal imaging. So if we see the indications for fetal MRI, so there are not definite guidelines laid down for the fetal MRI, and there is some discrepancy. If you see the American guidelines like the ACR and the Society of the Pediatric Radiology, they say that its role of fetal MRI is very limited, like when the ultrasound has seen an abnormality, but it is not able to define the abnormality because of some factors like oligohydramnios, or because of the advanced gestational age and the baby is so large, so that ultrasound is not able to identify it, or because of the maternal obesity, or the another institution can be ultrasound has seen the abnormality, it is able to define, but for the management purpose, we need some more information. Like say, for example, if there is a congenital diaphragmatic hernia, ultrasound has already diagnosed it, right? But the clinician wants some calculation, some volumes, like Dr. Doda has already shown one nice case of CDH, where MR can be used for the calculations of the lung volumes and few parameters like McBone index and PPHI, and which are the parameters which can predict the postnatal chances of the pulmonary hypertension. Or the another third indication can be the when we know the fetus is at risk, like in TT as in the twin transfusion syndrome, where after the ablation we know that the fetus is at risk for the ischemia of the CNS system. So even if the ultrasound is normal in this kind of patient, MRI is advisable. But when we see the European guidelines, so according to one of the study, which I would like to quote, Meridian study, which was published in the Lancet journal in 2017. So according to that study, the accuracy of the ultrasound for detection of fetal anomalies was around 70% before 24 weeks. And it reduced to around 64% after 24 weeks, right? Because of the factors which we know already discussed, like advanced gestational age and size of the baby. But when they did an MRI as an adjunct to the ultrasound, this accuracy was drastically increased to 92% before 24 weeks and 94% after 24 weeks. So what they concluded, they suggested, they advised that any fetal brain abnormality detected on ultrasound should be subjected for the fetal MRI. That was their suggestion. So there is this discrepancy. But having said that, after 18 weeks, we know that before 18 weeks, usually we don't do the MRI because of the organogenesis. Although there are no scientific data that suggests that there is any disadvantage or harmful effect on the fetus or mother by the MRI. But so after 18 weeks, 18 to 24 weeks, and after 24 weeks. So before 24 weeks, and the most common indication that we get for the fetal MRI is the ventriculomegaly. So what happens in ventriculomegaly, the causes like corpus callosinosis or some migration anomalies or intraventricular hemorrhage. So particularly these etiologies can be missed by the ultrasound, and MR has a superior spatial resolution and accuracy for detection of the abnormality of the corpus callosum cortical malformations like scaling cephali, heterotopias, or like vertebral anomalies like hemivertebrae or butterfly vertebrae. So definitely, so MR has got an advantage for the data, and especially like Dr. Doda sir also showed one case of hemorrhage. So I would like to also add one thing that apart from the routine sequence that we do haste and fasting SSFE image, if we suspect intraventricular hemorrhage or cerebellar hemorrhage as cause for the IVH, then we do an additional diffusion weighted images, because we can nicely pick up the hemorrhage on the diffusion weighted images.
Okay. So thank you, Dr. Swapnil. And Dr. Vanda.
Yeah, thank you for the excellent talk, Dr. Doda. And again, as a practicing fetal medicine specialist, I would like to add that when we see a CNS anomaly on a screening examination, so once an anomaly scan has been done and we suspect something, I would suggest that an extended neuroimaging be done by a specialist who's used to seeing the fetus, who knows the entire workup. So for example, if I take the example of ventriculomegaly seen at 20 weeks, I would probably like to do a very extended neuroimaging for this fetus around 23, 24 weeks. And then maybe the MR can be done around the 26 weeks, where you can look at the sulci thyroid and the migration anomalies, etc. will come up later. So just after screening, if you're sending for the MRI, then there is a certain lacuna in the workup of the patient in terms of which invasive tests to be offered, and also, you know, it gets a little incomplete, the workup. And yeah, I agree that one of the commonest indications in our practice also for doing MRI is fetal MRI is the fetal ventriculomegaly, the isolated mild ventriculomegaly between say 11 to 12, 13 mm, where the parents are really keen to continue the pregnancy. So those are one of the commoner indications, and an agenesis of the corpus callosum, again in a setting where parents are counseled and after all the workup is normal, the invasive testing is normal, our own extended fetal examination is normal, then the MRI could be an adjunct. And it might add 1 to 2% more information than what we've got. But I think medical legally also, and from the parents' perspective, it makes sense to do MRI in these. And Akrita is something also for increasingly we see that we are doing fetal MRIs for Akrita, and that adds a lot of confidence to the obstetrician, because people who are practicing in the lower tier centers, they don't feel confident unless both ultrasound and MRI have given them the clearance that it's not a theta. So these are the common indications. I think for diaphragmatic hernia, we have a lot of our own ratios, OE, LHR, etc. But the MR definitely may score better, but there's a lot of there's of data there in terms of prospective studies. So we are still looking at that. And most of the other stuff, I think we can still manage on ultrasound. I think these are the common indications practically that we've seen.
Yeah.
I would like to add one point here. So as Dr. Vandana said, after the extended neurosonogram, we can do an MRI in the second trimester. So according to this one study published in the international, I think, journal Ultrasound of Obstetrics Gynaecology. So even after the extended neurosonogram, when they labeled it as a mild to moderate isolated ventriculomegaly, and when the fetal MRI was done in this patient, the MRI detected an additional abnormality in at least 5.4% of the patient. So even after the extended neurosonogram, fetal MRI has an added advantage in an isolated mild to moderate ventriculomegaly patient.
So, yeah.
I'd just like to add a little bit that there is absolutely no doubt that MR is somehow being done much, much less commonly. And we all know that MR as such does not have any harmful effect. You know, there is, there is a need to exploit the MR technology and those advantages of multiplanar imaging and the superior contrast and various sequences to highlight the fat and hemorrhage and those hidden areas of fetus, you know, hidden corners of fetus, you know, once any, doubt is there, there is a little bit of that, as I was saying, that once you're not comfortable in your mind, you want to take the help of other imaging modality, which we do every day. We pick up a patient of MRCP for bile duct and take them to ultrasound, or the other way around. And we do at least 2 CT scans in MRI cases every day out of 30 odd MRIs to get a little more information about the cortical bone. I'm talking about the general cases. So sometimes you want to have the help of a second imaging modality to boost your confidence. And of course, MRI also shows exquisitely the anatomy of all the fetal parts. Should be used more commonly.
So there is one study by the Ashma Khalil. The people working in the fetal medicine, they would know that there is a European Neurosonography working group. And as per them, which Dr. Swapnil has already said, that the detection rate extra is about 5%. And what are the areas where the detection rate is more? One is the intracranial hemorrhage, and the second one is the neuronal migration disorders. So these are the 2 areas. So we conclude finally that, of course, the neurosonogram has come up, but I personally feel that, not everybody is well equipped with the doing neurosonogram. Not every hospital has got, but fetal MRI, the MRI is available everywhere. So so we can utilize both the modalities. If the neurosonogram is available, we should use that, and if the MRI is available, we can use that, because both the modalities, the imaging modalities, are complementary to each other, and ultimately the diagnosis, so that they can help us in making a right diagnosis. So I think with this we move on to the next session. Yeah, Dr. Nidhish is not there. I think he was supposed to conclude. Dr. Nidhish? Oh, we can't identify you.
Yes, ma'am. Actually, I've just left from hospital. I'm so sorry.
Okay. So you are supposed to conclude the session.
Yes, thank you, ma'am. First of all, thank you, Dr. Doda, sir. And as usual, it is always pleasure listening to you.
Yeah.
And you have made to look fetal MRI so simple and so easy. And Swapnil, you have put in so much relevant and valuable points and inputs. But the thing what I would like to share here is, after listening to all of us, I believe we need to have more and more studies in this regard of fetal hemorrhage and migrational disorders. And one thing what I would like to say here is the fact that MRI answers all the questions may not be true every time. See, as in most of the times, Swapnil and Dr. Doda sir would agree with me that obstetricians would they would send the patients without any understanding indications properly, and then they would be asking whether the MRI can answer all the questions or not. And the other thing is, as we all know that decent for a decent fetal ultrasound, there are certain accreditation bodies like FMF, who can certify and help in acquisition of certain level of expertise in ultrasound. But the qualification for fetal MRI is just to have a magnet. This sounds slightly funny, because there is a lot of problem in there is responsible there is a lot of problem in understanding and image quality acquisition and reporting all over the town. There will be a lot of problems. So and Dr. Swapnil and Dr. Doda would agree with me that for a good MRI we need to have at least 20 sequences. And you know what, fetus keeps on moving, and we are really not always to get a single beautiful sequence where we can answer. So we actually land up taking 20 sequences, and a lot can go wrong if the sequences are not used correctly. So these are few salient points with what I was thinking about, and I wanted to share. Rest, it's always pleasure to be part of this, academic feast. As Dr. Seema and Dr. Tina, you have invited us from the non-obstetric planet, actually. Myself, Dr. Dora and Dr. Swapnil. It's always pleasure to be part of your academic feast, ma'am.
Yeah, that is all combined effort, Dr. Nidhish. It's all multidisciplinary, actually. The more you grow, the more you become, that how important is the, to involve everyone, because after all, the patient care requires expertise of everyone.
Definitely. And it's always pleasure, being part of all this academic feast. And we look forward to this every month, actually.
Yeah. Sure. Thank you, Dr. Nidhish. So Dr. Nidhish is doing wonderful job as a fetal medicine expert. He is a very good fetal intervention, does very good fetal ultrasounds. So he has his own views about the fetal MRI. Doctor, so about the, I had one question. There is one question in this. So Dr. Nandita Dimri, she is asking, how do you control the movement? So the question is to Dr. Doda sir. So how do you control the fetal movements to ensure the precision?
Now, you see, one is that definitely you can give sedation to the mother. There is absolutely no doubt. It's very well documented that if required, you can give sedation to the mother, and that helps in reducing the movements of the baby. Otherwise, you have to keep repeating. And one of the problem areas, as Dr. Nidish was just pointing out, that we have to take 20 sequences. I can put it in another way, that MRI is a time-consuming thing. Sometimes you have to keep repeating the same sequences to get the details because the baby is moving. We try and avoid giving sedation as far as possible, but it is not that you cannot give sedation to the,
and how much time on an average
especially in the
do you
late
require
second
for fetal
trimester.
MRI?
Definitely about 45 minutes to 45 minutes to 1 hour to do MRI.
So till the time the mom is inside.
Yes, definitely.
That's yeah.
In case, since it is towards the late second trimester and third trimester, it is reasonably well tolerated. If it is not, you can put the woman left side down position and you can still do. That's the advantage of MRI. You can do it in any plane. So that
how
is
much radiation?
mentioned.
Like we know, we code them as either milligray or 5 rad. So how much
MRI has no radiation. Like ultrasound, MRI is normally speaking absolutely harmless.
It's entirely
absolutely harmless. There is
no exposure, nothing.
Absolutely.
And this is non-ionic.
You can put one person from the family inside to make the lady more comfortable, as we do with any other patient also. Because it has no harmful effect.
Actually, ma'am, there are no studies in the literature that have reproducibly proven deleterious biological effects by static magnetic field on human tissue. So it's really relatively very safe. So it can always be used pregnant ladies.
Because that's a very common question asked to me: is MRI safe? Both
static magnetic field is not going to have any effect on human tissue as of now.
So because this is non-ionic, and what about the contrast? Because many times they would come with some contrasts.
I would like to answer the question. May I?
Yes, please.
I think most of the time contrast is not required. MRI has got enough spatial resolution, so contrast is not required. And even if it is required for other reasons, so it should be avoided at least in the first organogenesis phase. And at least one thing that we know is it is not a teratogenic. But definitely the studies are lacking because no scientific studies are done for the use of contrast in antenatal science.
So there are what we read as non-iodinated. So which one do you use?
As I said, ma'am, it is not required.
Not required, but many a times we get reference for that. That women has undergone some procedure for that, and the contrast has been used. So whether they should continue and all. Of course, this is not related to.
So there is no scientific data available for the contrast study, whether it has any harm or not, but definitely it is not teratogenic.
So the gadolinium you suggest, because it had a lady with brain tumor. That's why I'm asking. And she was in the first trimester.
Okay.
So but they wanted to perform
in the first trimester
MRI brain. So then we
in the organogenesis phase, we should avoid the contrast. Definitely, we should see the risk-benefit ratio, which is better for the patient, whether the pregnancy or the.
But if indicated, it can be done. Yeah.
Yeah, it can be done.
The risk-benefit ratio
may be avoided before getting this.
Okay, so I think thank you, sir. Thank you, Dr. Swapnil. Thank you, Dr. Nidish. So,
thank you,
Dr. Vanna. With this, we move on to the next session. That is a panel discussion. So, Dr. Tina.
Yes. Shivam, can you please?
Himanshu.
Yeah. Okay. So we are moving on to the third session of this CME, and it is a pleasure to introduce Dr. Chanchal. She's a senior consultant and lead consultant of fetal medicine in Madhukar Rainbow Hospital, and she has done her MBBS, MD, and MRCOG UK. She is trained in fellowship in maternal fetal medicine from Singapore and is accredited from Fetal Medicine Foundation UK. Her areas of interest is antenatal screening, high-risk pregnancy, especially fetal growth restriction and multiple pregnancies, and fetal interventions. She is a academician and has published more than 25 papers in peer-reviewed journal. She is presently the current member and the past chairman of AOGD Fetal Medicine and Genetics Subcommittee. She is in the editorial board of Journal of Fetal Medicine and a current member and representative of International Representative Committee RCOG North. She also has in the current center FOGSI accredited ultrasound trainer. Moving on, welcome ma'am, welcome aboard, and thank you for moderating the session. Dr. Seema ma'am, she is really, she doesn't need any introduction. She's the chairperson of the Genetic and Fetal Diagnosis Committee of the AOGD. She is presently in the Fortis Hospital, Shalimar Bagh, Delhi, and also working in Rainbow Children Hospital, Delhi, and has a genetic clinic in Dwarka. She is trained in medical genetics, and she has received 3 years DM genetics training from SGPGI Lucknow. Very less people in India are actually trained in, specifically obstetricians who are trained in medical genetics from SGPGI. She has a work experience in the field of genetic and genomic counseling and prenatal diagnosis. She's a recipient of title of Professor 2016 to 19 by Apollo Hospital Education and Research Foundation and a Distinguished Medical Luminary Award 2021 IMA Women Doctors Association Delhi. She is also a DNB examiner, current chairperson AOGD Genetics and Fetal Medicine Committee, Vice President of DGF Dwarka 2021-23, and she has more than 50 publications, including publication in Nature Genetics and American Journal of Medical Genetics. Welcome aboard, ma'am, and thank you for enlightening us.
Thank you, Dr. Tina. So now I would invite, I'm delighted and it's my privilege to introduce Dr. Kaval Gujral ma'am, whom I know since when I was working as a assistant consultant at Sir Gangaram Hospital. And she doesn't need any introduction. If you name one obstetrician whom everyone knows, probably and one name will come as Dr. Gujral. So rightly so, because she is in charge of high risk pregnancy clinic at Gangaram Hospital. She has been past president Narchi Delhi, past vice president AOGD Narchi, past vice president of Narchi. So she has got lots of feathers attached to her, and she has been past joint secretary Indian Menopause Society, past national vice president Narchi, past editor of Journal of Fetal Medicine India, past president of DGF Central. She is an advisor for DGF Central and president for Society of Fetal Medicine Delhi chapter. And she is also a member of editorial board working group and current medicine research and practice, and published papers and chapters in books and delivered guest lectures, national and international conferences. IOG Satya Paul Award 2017 for her excellence in high-risk pregnancy management, and Medgate 10th MT India Healthcare Award 2020, for the most promising doctor, obstetrician and gynecologist. So I welcome ma'am. So I'm happy to introduce Dr. Savita, who is a very good fetal medicine specialist, and she is an MBBS from Lady Hardinge Medical College and has done MS in Obs Gynae from MAMC, senior residency from MAMC, and currently she is working as her own clinic, which is a Joy Healthcare attached to the Venkateshwara Hospital. And her areas of interest include management of high-risk pregnancies, screening and diagnosis of fetal abnormality as early as first trimester, fetal interventions and therapy, and she aspires for affordable, sustainable, and quality care for all. And so welcome, Dr. Savita. So next I would like to introduce as a panelist, Dr. Anita Bansal, who is an HOD for Obs and Gynae, Northern Railway Central Hospital. So welcome, Dr. Anita. Next panelist is Dr. Jaya Chawla, who is MS, FICMH, Fellow of Maternal Fetal Medicine, obtained from AIMS, Delhi. And she is currently working as Associate Professor, Department of Obs and Gynae, RML Hospital. She is an executive member of Society of Fetal Medicine Delhi chapter. She is a member of Multidisciplinary Committee AOGD 2022 to 24. She is a coordinator of International Childbirth Initiative and faculty for the Medical Education Unit. She is a postgraduate medical teacher, undergraduate examiner for Delhi University and Maharashtra University also, peer reviewer for Journal of Fetal Medicine and Journal of Obs and Gynae India, multiple national and international publications for chapters, guest lectures, and her field of interest is fetal cardiac arrhythmia, something very tough topic. So I think we would love to, understand from you in next session, and not in this session, in next webinars or some. And another area is prenatal screening. Both are very important areas. So next slide. So now I welcome Dr. Prashant Johari, who is a MD and DM Pediatric Neurology and Associate Professor at Chief Child Neurology Division, Department of Pediatrics, AIIMS, New Delhi. He is an Associate Professor of Child Neurology and Faculty for Child Neurology DM program at AIIMS, New Delhi. He is a DM in Pediatric Neurology from PGI Chandigarh and MD Pediatrics from Lucknow. And he has publications more than 80 in index peer-reviewed international journals, contributed chapters in 24 books, and a principal investigator in many extramural and intramural funded projects. His area of interest includes fetal and neonatal neurology, pediatric epilepsy, and electrophysiology. And he is a reviewer in multiple international and national peer-reviewed pediatric and neurology journals. So welcome, Dr. Prashant.
Thank you, ma'am.
So Dr. Chanchal, now I request Dr. Chanchal.
Thank you, ma'am. Thank you for the kind introduction, and thank you for introducing all the panelists. So today, I think with increasing resolution of our ultrasound images and the increased understanding of the fetal brain formation and physiology and embryology, we are seeing more and more. And once you see more, you need to interpret it better. So I think nowadays the problem has become more of which findings should we get worried about and which findings should we not get worried about. So it's a very pertinent topic that has been chosen for today's webinar. And our panel is expected to discuss diagnosis, management, and prognostication of common fetal CNS malformations. So
full screen, yeah, slideshow.
Yes.
Full screen this.
1 minute.
Yeah.
So we'll start with the first case. 32-year-old priming gravida, singleton pregnancy, 20 weeks, gestation currently. Her first trimester screening was low risk. And the anomaly scan reported bilateral choroid plexus cyst. And anytime you flag something in the fetus, it creates a lot of anxiety. So Dr. Kamal, this patient comes to you and she's very anxious because the doctor mentions there are cysts in the brain. So how would you counsel this patient?
Thank you, Chanchal. Good to see you again. Well, we all know, and at the Fetal Medicine Forum, we know these are benign things. If the first trimester screen is normal, there's no other associated anomaly with a good ultrasound, and there's no bad obstetric history as well. We know that it has some association with trisomy 18, but we do not see any criteria with a normal first trimester screen. I think we take it as a finding that 99% it will go away by 26 weeks. And standard obstetric care, standard obstetric management, standard timings for the ultrasound as you decide, nothing special, and as well delivery. Now you said counseling. Yes, you have to tell the patient in her own language what does this mean. Because my experience with obstetrics says that anything wrong with the brain, my God, the thing is going to be a sub-intelligent child or a mentally retarded child. I think you have to speak in a language that this is a normal variant. It does not have any bearing on the outcome later. Your baby will be as intelligent as you parents are, whatever the intelligence you want it to be. This is what. And I was looking at the data on the counseling, and Jaya is a part of this paper where she said that in spite of adequate full counseling, 80% of the women still were worried, concerned that there is something wrong with the brain of the baby. And 71%, despite counseling, sought to an internet. So I think it's time and again tell them this baby is going to be normal as if it was without a CP cyst. That is how we close the discussion.
Absolutely, ma'am. So we really, because it does create a lot of anxiety. So the counseling, and when it's when we scan and we tell them the same thing, it's never the same when you tell them that. So I think the obstetrician, they have inherent, they meet you more, they have more faith in you. So I think it should come from the obstetricians. It holds more value.
We should not worry ourselves and worry our patients, is what we realize.
Yes.
Half of us actually make it a very big issue. That's it.
Yes.
These are the only benign brain findings, I would say.
Right. Right. So coming to the next case, 34-year-old priming gravida. This was an IVF conception for unexplained infertility. Again, a singleton pregnancy at 20 weeks. The first trimester screening was low risk, and the anomaly scan reported a dilated third ventricle, and she was sent for a repeat scan. So this is the ultrasound which was done with us. Would you like to comment on the ultrasound images, Dr. Savita?
Yes, ma'am. So on the axial section, we are seeing this midline anechoic cyst, and on the sagittal section, we are seeing the same cyst. So this is looking at the position. This is most likely a cavum interpositis cyst, which is actually it is an anechoic. Am I audible?
Yeah.
Yes, but you can be a bit louder, Dr. Savita.
Yes. So, ma'am, in the axial section, we see a dilated structure, a small avascular cystic structure, and also in the sagittal section, we are seeing it is located at the inferior end of the corpus callosum. So, this is very specific for the cavum villi interpositis cyst, and cavum villi interpositis cyst is actually a double-layered space in the tila chordae of the third ventricle. And usually if in such a case, we like to do a detailed neurosonogram and look at a detailed anomaly scan. And most of these are a normal variant, and they usually resolve in subsequent scans up to 4 to 6 weeks. And isolated cases, the outcome is very good.
Yes. So I think, as I said, with increasing resolution and with increasing use of transvaginal scan, we are seeing these findings more and more often. So, and that is why literature is also coming in recently. As Dr. Savita rightly mentioned, that it is various degrees of fluid accumulation. It's in the velum interpositum actually gives rise to physiological CVI. And if it warrants follow-up, we call the patient back after 4 to 6 weeks. And once a neurosonogram has been done and the associated structures are normal, and they will have a favorable postnatal outcome with no impact on long-term development. So, Dr. Savita, we call this patient back after 4 weeks. Can you just explain what we are seeing? Just comment on the normal structures also.
So, ma'am, this is a sagittal section of the fetal brain, and we can see a nice corpus callosum. And if it is of that same patient, I think then the cyst has disappeared. We see a nice vermis and the brainstem. The vermis brainstem angle is normal, and to me it looks normal.
Absolutely, it's the same patient, Dr. Savita, and this baby was. I mean, this baby is born now. It was a full-term normal vaginal delivery, just born, but did not need any further follow-up for that. So that's the second variant, which we can probably put together with the CPC. Does warrant to follow, especially when they're more than 7 millimeters, but otherwise physiologically. Now, Dr. Prashant, I did not have a case of an intracranial arachnoid cyst, so I've just taken it from the net. So it's uncommon, but occasionally one would come across a finding of an intracranial arachnoid cyst. So on our part, we would scan and make sure that the rest of the structures are normal. So Dr. Prashant, you being a pediatric neurologist, I would want your opinion on how do you counsel these patients and what postnatal management should the parents be told? Dr. Prashant?
I think he hasn't joined. Dr. Tina, I think he hasn't joined. No? So I think you can move on.
Dr. Prashant, you have to unmute your mic.
Is he here?
Yeah, he's there.
Dr.
Prashant, you have to unmute your mic. Are you able to hear? Okay.
Okay, am I audible?
Yeah.
Somehow I was not able to unmute actually. So, it's compared to the previous cyst that Dr. Savita described. So this arachnoid cyst, this comes with a different sort of a pattern. So many a times this would be associated with some other anomalies, and you need to do actually a formal evaluation and neurosonogram so that you pick up, is there any other abnormality or not? And the outcome would to some extent depend upon what is the site where this is occurring. Is it the middle cranial fossa where it is occurring? Is it the posterior fossa where it is occurring? And then whether or not it is present in isolation or we have some other mass effect which is there because of this. So in case you have these mass effects, then the possibility will be there that some symptoms may be there in the postnatal life, and a small subset might require a shunt surgery. They could be hydrocephalus. But truly speaking, in my experience over 12 years, what we see is that even arachnoid cysts are majorly incidental in nature. So they don't pose a major cognitive impairment that someone has to worry a lot, that they have to think of any some sort of a termination of pregnancy. But yes, we need to be telling them, yes, there would be a subset which can have a variety of problems. There can be some focal seizures which can develop later in life. They can have migraine, but as you all know, these are all treatable things. So to me, this would be considered as a less severe anomaly or a benign abnormality, I would consider. But yes, compared to the cavum interposititis, generally this would stay, it doesn't regress and may have some bearing later on.
So on our part, we would do a complete neurosonogram and follow them up every 4 weeks to see whether it is increasing.
That would be required to see whether the size is increasing, whether there is any mass effect that is developing, so that then you need to accordingly plan your delivery and postnatal management if it requires.
Any role of invasive?
So if it is present in isolation, then it is generally not associated with any chromosomal abnormality. So generally it is not required currently any invasive testing to do that along with. And postnatally, if you are detecting it, then the chances is that unless and until it is there in the posterior fossa, where at some times there could be requirement of shunt surgery. Majorly, the 40 to 60% it will be there in the temporal lobes, and there generally it is considered as an incidental or a benign finding.
Is there any size also, size by which we decide the prognosis?
So if you see, if you have site is more important, if you have an interhemispheric arachnoid cyst, then the chances would be there that it is associated with callosal abnormality. So there it would have a bearing on your neurodevelopmental outcome. If it is not there, then the size has to be seen in proportion to the other areas. So if it is creating a mass effect, it is compressing the cisterna magna, if it is compressing the sylvian fissures, then maybe we'll have to follow it 4 weekly. And if it is increasing, then maybe we'll have to have a early plan for a shunt surgery the moment the child gets received. So in that scenario, which would be actually very rare. So what the literature says that maybe a third might require some sort of an intervention. But when we see pediatric patients as a whole, we see them a lot of vague symptoms are there, and this arachnoid cyst comes as an incidental finding. So we in the postnatal life, we don't regard it as a major problem which is related with the symptom. So there can be some subtle developmental abnormalities like learning disabilities or occasional seizures, but we don't have a causal relationship with arachnoid cyst.
So you don't aspirate and all?
We don't, unless and until we see that there is some sort of a compression is happening on any of the brain structures.
Okay.
And that would be 5% or 10% at the most.
Right. So that completes the list of intracranial cysts that we encounter. Now coming to the next case, a 35-year-old priming gravida who conceived with IUI, and her first trimester screening was low risk. And then she comes at 20 weeks and there is, can you comment on the scan findings, Savita? Dr. Savita?
Yes, ma'am. So in this picture, we are seeing that it doesn't look very good. The ventricle is looking dilated. The lateral ventricles, the posterior horn especially is looking dilated. The cavum also is not nicely formed. And we also see a midline anechoic structure, which is like a dilated third ventricle. So, and when looking at this plane, it looks very much like agenesis of corpus callosum.
Let's first, so I thought that we'll discuss the mild ventriculomegaly first. So there is ventriculomegaly. How would you measure the ventricle? What is the correct plane of measurement?
So the ventricle has to be measured, lateral ventricle has to be measured. We have to look at the parieto-occipital fissure. So and in line with the parieto-occipital fissure and at the level of the glomus in the lateral ventricle, we measure it from inner to inner. That's the right way of measuring the lateral ventricle.
Yeah. So not outer to inner, as you rightly mentioned, that it is inner to inner. That's how it should be measured. Because many times most referrals that we get for ventriculomegaly, and when you look at it in the current plane, most of the times the measurement falls within the normal range. And what is the cutoff to define ventriculomegaly?
So ventriculomegaly is divided into two categories, the mild and the severe category. So 10 to 15 is the mild ventriculomegaly and severe is more than 15 mm is the severe ventriculomegaly. Right. And also you have to see it's unilateral or bilateral.
And 10 millimeter is the same across all gestation.
All gestation after
many times we get a referral that at 18 weeks or at 17 weeks, the ventricle is 8 millimeter. So it's prominent and then they get referred. So across all gestation, a cutoff of 10 has been uniformly adopted as to define ventriculomegaly. And Dr. Jay, would you like to just comment on the slide regarding the mild and severe ventriculomegaly? How does what are the associations between mild and severe?
Precisely. Actually, ventriculomegaly per se is not a diagnosis. It is assigned to something more abnormal, and the etiology can vary. And that will decide the prognosis for a certain case. And that is where the distinction between the mild and the severe category, as has been proposed by the Society of Maternal Fetal Medicine and other professional bodies, comes into play. The mild ventriculomegaly, we all know, has a likelihood ratio of 3.8 as a soft marker for diagnosis of Down syndrome. So the association there happens to be more with chromosomal abnormalities, aneuploidies, genetic syndromes, etc. Whereas the severe variant is more likely to be associated with obstructive pathology of the ventricular system. And that is going to be on a totally different tangent insofar as the outcome for these babies is concerned. And counseling on these lines is very important for the patient population who comes to us, because the main concern is how is the baby going to end up. So when we know the foundations of our diagnostic workup, we go accordingly.
Yeah, so Chanchal, I have one question. Yes, what is asymmetric ventricles, or is it, should we worry about, or should we measure both the ventricles, the upside and downside, both? In ventriculomegaly, you said that, at the glomus you should measure, but should we measure the both?
It's always a good idea to look at both the ventricles because it can be unilateral. So when we are talking about a ventriculomegaly of more than 10 millimeter being associated with chromosomal abnormalities, it can happen at any side. So, and one is able to do it easily on the scan. So one should measure both, and the asymmetry is relevant only when one is more than 10 millimeter. So both ventricles, one is 7 and one is 8.9, that is okay. And all the panelists can intervene, and please stop me if Dr. Prashant, if you have a different point of view. So in our antenatal literature, so the ventriculomegaly or the asymmetry starts mattering only when there is ventriculomegaly, not otherwise.
Okay, so if one is 7 and the other one is suppose 3, then we should not worry. So as long as it is within 10, it is not asymmetric ventriculomegaly only when it is 10. Okay.
So one of them has to be dilated for me to call it ventriculomegaly, and then I can look at it whether
there is lots of confusion that and the difference is just 2 millimeters. So that's
Yes. No, one has to be more than 10 millimeter.
I fully agree, Dr. Chanchal. In fact, if you happen to see an asymmetric ventricle, you need to see the other structures as well before you actually comment. And as Dr. Chanchal has rightly said, if it is beyond 10 mm, then it should be of concern. And truly to lead it to some neurodevelopmental outcome, it has to be more than 15 or 20. That is it has to be towards the severe form, and then the possibility of having some significant abnormalities only comes up.
Right. So Sorry. So then, Dr. Jay, we were talking about the diagnostic workup. So once you see ventriculomegaly, how would you go about working up this patient?
As we've already talked about the fact that this is a sign that needs to be deliberated further upon. So we need to first look at what system is already abnormal. We are seeing a ventriculomegaly, so CNS is definitely the point where we begin, and we offer a detailed neurosonogram to this lady. And for this to be done, we need to look at the infratentorial as well as the supratentorial compartments. In the infratentorial compartment, you've beautifully seen in Dr. Tina's videos that there can be evidences of open neural tube defects, along with there can be an issue with posterior fossa formations leading to the Randy-Walker spectrum. So we need to look at both ends of that spectrum and see further. Apart from that, we need to look at the supratentorial images, the anterior complex, to figure out if we are looking at a holoprosencephaly, say for example, or there's any evidence of agenesis of corpus callosum with its spectrum of further workup that we might require, or there can be issues with the septum pellucidum that we need to deliberate further upon. Also, the look of the ventriculomegaly per se can give us some insight about the etiology, how it has developed. So if we have periventricular calcifications and we look at synechia, then we're probably looking at an infective pathology. And therefore, definitely, even otherwise, the component of serology, maternal infection serology in terms of TORCH, IgG, and IgM would be required in these cases. And if we have a baseline serology, prenatal testing, or maybe first trimester testing, that is going to be great help in that particular regard. Apart from that, we can have evidence of hemorrhage when we do not see a completely black ventricle, an equilucent ventricle, so as to say, if we see debris over there, we see hazy ventricles, then we're probably looking at an hemorrhagic etiology. And for that, maternal workup for antiplatelet antibodies, along with the partner, that is going to be of very grave help and give us an insight into the management of that particular case as well. Apart from that, there can be tumors, there can be space occupying lesions in the brain, which can also give us an insight into why this ventriculomegaly is developing. Apart from that, you have to look at the size of the head. If we are looking at a small head, less than the 5th centile, less than the 3rd centile, then we're probably looking at infective pathology in terms of CMV or maybe Zika. So all of these have to be put into perspective. That is the neurosonogram. Apart from that, we have to look at the entire baby, the different systems which can be involved in this particular case. And then we'll be able to arrive at certain genetic syndromes if we pick up findings from different systems. And the association of these is likely to be the tune of 50% or so in this particular case of ventriculomegaly. Having talked about maternal torch profile, we also have to look at the genetic aberrations which are associated with ventromegaly, as we have already discussed. So we have to perform an amniocentesis and offer a QF-PCR for the common 5 chromosomes, followed by a chromosomal microarray, which is the current recommendation by the ACOG as well as the Society of Maternal and Fetal Medicine. So we delve into that deeper, and the association is to the tune of 10% or so. Apart from that, we have to emphasize the fact that fetal medicine is not a cross-sectional branch. We have to keep this lady under follow-up, evaluate every 4 to 6 weeks, because brain is an evolving organ. So what we may not be able to see today in the neurosonogram, we might have to pick up at a later stage, and that might completely summarily alter counseling for that particular patient. In addition to that, if we are seeing this lady at say around 24 weeks or so, then as we have had a detailed discussion with Doda sir, etc., that MRI can come to our avail to have a knowledge about more of the cranial abnormalities, more of the associated extracranial abnormalities, and also we can look at some disorders of neuronal migration, heterotopia, etc., which may not be adequately picked up on a neurosonogram. Having said that, our workup always has to begin with a detailed history regarding comorbidities, any teratogens, any substance abuse, age of the lady, combined first trimester screen. All of this has to be put into a jigsaw before we guide the patient further.
So the main purpose of putting this dense slide was to put across the fact that ventriculomegaly is just a symptom, and it has a varied etiology, and the prognosis depends on the underlying etiology. So a detailed workup is needed. Now, coming to our patient, Dr. Savita, that's the, I put a video here. Can you comment on this video? Savita, and I think you're muted.
Unmute yourself.
Yeah, unmuted. Okay. Just play it once more, please. Okay, so in this, we see there is a teardrop lateral ventricles are visible, and the hemispheric fissure is wide, and the cavum is not nicely formed. So this goes more in favor of agenesis of corpus callosum.
So you can barely see the cavum. There are these parallel lines and the typical teardrop appearance of the lung.
Teardrop, and the fissure is also widened.
So in this, so our diagnosis was that of an agenesis of corpus callosum. So once you've listed your diagnosis to agenesis of corpus callosum, she's had prior screening, which was low risk. It's a young girl. How would you go about working her up now? What would you do?
Again, we have to look at the neurosonogram yet again to see the associated abnormalities that we have discussed. And we have to look at the other systems in order to figure out whether we are looking at a certain genetic syndrome in which this particular case falls. Because of the genetic association with both complete as well as partial agenesis, we have to look at our amniocentesis and a microarray to be able to be certain that we are not dealing with a genetic syndrome in particular. And once we have done all of that, again, we need to look at an MRI to look at associated malformations that might be present and might have missed an eye, even with a experienced operator and a neurosonogram facility. We will have an incremental yield, as we have already discussed. And besides all of that, a longitudinal follow-up, and always with agenesis of corpus callosum, we have to put a gray block in our counseling, because there can be postnatal evaluation which gives us further information. So despite all the detailed workup we might do right up to whole exome sequencing, we can never be sure of what the postnatal evaluation is going to throw at us. And which is why it is extremely important as a fetal medicine person to suggest to the couple that postnatal evaluation is going to fetch more information. Longitudinal follow-up, stringent neurological follow-up of this baby is likely to give us more and more information, because all of what we have discussed in literature actually amounts to the length of the longitudinal follow-up that we have with these babies. So there can be concerns with speech, there can be concerns with social and behavioral aspects. We can have autistic disorders and so on and so forth. So depending upon the length of the longitudinal follow-up in these babies, we can have disorders in the school age group, in the speech part of it, in the very early age group also, and beyond the school age as well.
We'll come to the counseling, Jess. So now this patient, we did offer an amniocentesis and the microarray was normal. And so how would you counsel these patients regarding the long-term outcome, Dr. Prashant?
So I fully agree with what Dr. Jaya actually was talking about. So here now the spectrum, even if you say that it is completely in isolation, that the corpus callosum agenesis is isolated and we don't have any other abnormalities, then also the outcome is going to be varied. So here we all, those who are actually dealing with these parents, these mothers, you need to be non-directive completely. You cannot suggest something because it can actually vary. So how we can be more certain, more truthful is that first, if you start from very early, that first see, but what was the timing at which whatever scan was done and has been sent to you. So if it is quite early, then maybe, and the images, if you don't see your mid-sagittal and coronal images, they are not very clean and clear that you can actually yourself say, yes, it is an isolated ACC. Repeat it maybe yourself and see whether if it is actually an isolation or not. If we are sure that it is an isolation, then we can just suggest them, because if we don't find any abnormality in our neurosonogram, and maybe with a fetal MRI, the possibility would be that in almost say 70 to 75% cases, the child is going to behave normally. The developmental outcome is going to stay appropriate, but still 14%, 10 to 14% may have some mild borderline delay, and 10 to 11% can have some severe delay. So these severe delays would be majorly seen in those who have some monogenic or syndromic association. So though the percentage with isolated ACC is going to be less for these genetic problems, but still they can be there in up to 5% cases, and especially some metabolic disorders. So we can have non-ketotic hyperglycemia, which can present with neonatal seizures, and as a structural imaging, we can just have a CCHL. We can have a Cardi syndrome for that matter. So all these things are there. So you can be non-directive and tell them, okay, this is the stratification. And yes, if there is a partial agenesis, Then depending upon whether the anterior part is obstructed or the posterior part is thin, we can have slightly different, we can know what would be the possible etiologies that is coming in, and maybe we have another case scenario based on that. So I'll restrict myself up to answering to a complete agenesis.
Yeah. So this couple decided to opt for termination of pregnancy. So Dr. Seema, what postnatal workup would you suggest, and what would be the recurrence? How do you counsel these parents for the next pregnancy?
So basically, as already highlighted, that agenesis of corpus callosum can be part of the genetic syndromes. As per the literature, more than 200 genetic syndromes has been reported in association with the agenesis of corpus callosum. So we require fetal autopsy and the genetic testing. So among the genetic testing, the microarray has already been done, and which is normal. So as per the literature, in the yield of the microarray is about 10% in cases of the AGCC, that is the agenesis of corpus callosum. And beyond that, the role of the WES, that is the whole exome sequencing, and the literature shows that the association is about 20 to 40%. So I would do both the autopsy and the whole exome sequencing for this particular couple. And depending upon the results, we would counsel that what is the recurrence risk.
Right. So you would recommend a whole exome sequencing
and autopsy.
Yeah, and autopsy. And depending on the findings on the whole exome, would you test the parents further? And then
yes.
Right. Now, we will just to close the discussion on the prognosis of isolated mild ventriculomegaly. So, Dr. Prashant, I had just tried to amalgamate one of the causes. I wanted to address ventriculomegaly also in the panel because this is one of the most common findings that we come across on our antenatal scans. So, what would you say is the prognosis of an isolated mild ventriculomegaly? This is not related to the case that we have covered, that was agenesis. But if we do a neurosonogram and that is normal, we do a microarray, that is normal. We have done a torch PCR, that is not there on the. We have done PCR for viral DNA on the amniotic fluid, that is also not there. So what do we tell these parents? How would their child behave postnatally?
If it is just a mild ventriculomegaly, then the chances of good outcome is almost 100%, as you have already ruled out those positive things which could have predicted an abnormality. So in light of this, I would counsel them that the chances of having an abnormality is going to be less. But yes, definitely, I would actually keep him under longitudinal follow-up. I might want to like to repeat an imaging after 4 or 6 weeks and see how the ventricle size is behaving. So if it is not increasing, then I'm more sure that yes, this is going to be a mild variant only and might not lead to significant abnormality. Some subtle developmental coordination disorders or some subtle lower limb spasticity can be there, but which will be manageable. So more or less, I will suggest that this would be a completely insignificant abnormality.
Right. And so we come to the next case because I wanted to, we can see partial agenesis, we can see complete agenesis. So the next case, again, a 31-year-old primigravida. This was a natural conception. First trimester screening was low risk. And at 20 weeks, the scan shows partial agenesis of corpus callosum. Now, these parents are very keen to continue with the pregnancy. And we've done an amniocentesis and the microarray is normal. The neurosonogram at 24 weeks did confirm the finding and did not show any other abnormality detectable at 24 weeks. So now, would this finding, So I think the MRI has been discussed quite a lot. But Dr. Prashant, just to summarize, what is the role of fetal MRI in these cases when the parents are keen to continue?
So I would like to take a mid path between what Dr. Nidhish was saying and what Dr. Swapnil said. I would say that once the family has planned to go along with the pregnancy, so we should be giving them all the opportunities to detect any abnormality which could be there.
Absolutely.
So, and we have some studies which have good sample size. They are robust also, that have seen that there could be a possibility of 7 to 15% of detecting an abnormality on a fetal MRI over and above your neurosonogram and even an extended neurosonogram. And we should take this key. See, the brain is actually evolving. As a fetal medicine specialist, you all should also understand, maybe the corpus callosum, the structurally it is made, but the myelination is still progressing. So you cannot be 100% sure that what you are seeing at this point of time is going to stay the same. So that in these scenarios, I would suggest that MRI will have a role here to see if it is completely in isolation or there is any associated abnormality which is there. And maybe it to sometimes it people have studied that yes, there would be 5 to 10% chances that they have negated what was falsely diagnosed as a partial agenesis of corpus callosum based on a neurosonogram. So in that way, I will recommend, and in fact, the ICOG has also recommended fetal MRI as a part of evaluation for agenesis of corpus callosum.
Yeah. So I think the difference comes in as to when will you do it. So at 24 weeks, I think a neurosonogram will be able to give you as much information as that. But the main key to here is the timing. So if I have to do a fetal MRI, I think it's a third trimester, as you right?
Because the more mature it is going to be, then only we are going to pick up those gray matter heterotopias, those sulcations and gyration abnormalities, which we are actually worried about. So after 26 weeks, maybe that would be, or 30 weeks should be a good time. And now we also want to understand that the MTP rules have actually got modified. So we need to maybe around 26 to 30 week would be a good time where we can get this MRI.
Yeah. So a lot of, I think this discussion is patient-centric. There's a lot of individualization. Once these parents are committed, then they're committed. And then you give them the best of antenatal diagnosis, and then you can plan the MRI at a later gestation, which would give me more information. So would you, Dr. Anita, would this finding bear any change in the antenatal management of the patient?
Detailed counseling of the couple is very important. Those that have opted for the continuation of the pregnancy, many a times they do not understand what can be the outcomes. And like when we tell them that 70% of them are going to be normal, only 30% will have, 15% will have some minor problems, and 15% may have the severe neurodevelopmental delays. So sometimes they probably don't understand it that well. So a clear counseling has to be done. Otherwise, the standard obstetric management has to be done, and they have to be supported in their decision throughout the pregnancy. The delivery at term has to be there, and the mode of delivery has to be decided as per the obstetric indications.
So many times, ma'am, we often hear that now there is a problem with the baby. Yes, the parents have chosen to continue. And now, would you do a cesarean for fetal distress in this, or for a fetal indication? What would be your take on this?
The indication for the cesarean should be as per the proper guidelines. If there is a fetal distress and the baby needs a cesarean, it should be done, because the couple has already opted that they want to continue with the pregnancy. So we should give them the best outcome we can give.
Sometimes there's a lot of dichotomy that there is a finding, and should we do a cesarean for a fetal indication? I feel a fetal distress will not guarantee an intrauterine demise, and the baby comes out live. So you worsen the prognosis by adding on a hypoxemic intrapartum insult. So that these discussion has to be done antenatally, documented well in the notes. So, and parental wishes are to be respected. Now, Dr. Prashant, we come back to our question, the counseling regarding the long-term outcomes. Partly it has been covered. Is there any difference between a complete agenesis and partial agenesis? Because this couple particularly asked me, "Thoda sa to hai, doctor sahab, to theek rahega." Aap bol rahe ho completely nahi tha, tab bhi 75% theek rahegi. So, and how do you follow up these new needs? Yeah.
Okay, so again, there is a dichotomy on this. There are studies that say that there is a slightly higher risk of severe neurodevelopmental abnormalities when you have a partial agenesis compared to a complete agenesis.
Right.
But now we also need to look into the limitation of all this literature which has been actually thrown to us. So they are actually small size, and then this additional hypoxia which people have created because of continuation and not taking up surgical interventions there could have added to the insult which possibly this partial agenesis will lead to. Now, if we have an anterior part which is thinned out, then the possibility of a destructive lesion is there. And if we have a posterior part which is thinned out, then the possibility of some arrest in the development is there. So what we see clinically in the children with, say, spastic diplegic cerebral palsy who are born preterm, So they have this posterior thinning at times of CC. So this helps us to determine the timing of insult, and then we can see that, okay, there is an association. So we consider this would as a severe neurodevelopmental abnormality. So my take or my single sentence as an answer would be that they would have slightly higher chances of having significant abnormality compared to ACC, would be of the tune to of around say 20 to 25%. And 65% compared to those 75% that I quoted. These comes from two studies, one when done in 2012 and another was done in 21. These are very good reviews, you know. So they say that the possibility is slightly higher in partial agenesis of corpus callosum. I would be happy to take other people's opinion on this, but this is what we consider. And how we follow them postnatally is that the possibility of having some sort of a motor abnormality, some form of cerebral palsy is there. So we try to look at the early signs of cerebral palsy in these. We do a Hine evaluation in the neonate. We look at the general movements of these neonates, whether they are cramped, whether they are poor repertoire of movements are there, and then we follow them closely, how they are gaining milestones, maybe every 3 monthly. And we do this up to actually 24 to 30 months. If we don't see a major abnormality by that time, then the chances are quite less.
Right. So as it happens that once they decide that we are committed to the pregnancy, then they're not really interested in further workup. So they decline the MRI, and this lady had a full-term normal vaginal delivery. For the purpose of the panel, I called her 3 days ago, and she has a boy who, according to the patient, is doing well at 3 years of age. So there has been no objective assessment, but as per parents, there is no seizures, and the child is walking and talking. So they feel that the child is doing well. This patient has had a second pregnancy with us, and there was no abnormality this time, and this other child. Well, now coming to the next case, a 28-year-old family gravida, natural conception, singleton pregnant. Again, first trimester screening was low risk. This patient was referred at 22 weeks gestation for hepatic calcification. So you can see the calcifications here. So what would be the maternal workup here, Dr. Anita?
Since the hepatic calcification, so we have to think of major infections and the pulmonary abnormality. So we have to do a detailed ultrasound, laboratory ultrasound in each cases to look for calcifications outside of suggestive of any infections in the pregnancy, like fever or things should be taken, and sponge infection should be looked for. Cystic fibrosis can be there, but of course that the pregnancy to do before the pregnancy. But torch infection, the idea should be if we have the previous reports, then we can compare the two. Otherwise, we have to see whether IgG or IgM are positive or not.
Parental care is screening for cystic fibrosis that we would want to do.
Yeah.
Now, these reports, Doctor, as all of us obstetricians, there's a lot of echoing in the background. Can the
Manshu, please.
There's a lot of echo in the background. I think it has stopped now. So, as is the case with all of us obstetricians, these torch reports are a pain. I mean, so now we've done the torch for this patient. This was indicated because we were seeing a hepatic calcification. The torch IgM is negative, and IgG is positive for CME and rubella. How would you interpret it, Dr. Gujarat?
You see, as you said, there's a lot of confusion. Let's deal with CME first. Rubella is all right, IgG positive. We have the previous report, fine. IgM negative, IgG positive, 110 immunity discarded. Now, question of the CME, that we have to understand the real sequelae to the baby or congenital infection would be if she gets, it's the timing. If she gets to the first trimester, higher chances. As she gets in the later, chances of infection are decreased. And the way to interpret is only these IgM and IgG antibodies till we do a final diagnosis on M. The real test would be that we have a paired sera. When the woman gets the symptom, we study it, and when she gets out of it, we study it, which may not be possible. We don't have the history. So now, and whether it's a primary infection, which is harmful, reinfection, reactivation, anything can cause changes in the antibodies. IgM here is not that helpful for the simple reason that 75 to 90% of the cases IgM will be positive. It cannot tell us the time of infection. IgM can persist for a year after the infection. And IgM can, from negative to positive, it can become when it gets with another viral strain or even another virus like an Epstein-Barr virus. So for us, it is the IgG to understand. And as the chart is nicely shown, now our case is IgM negative and IgG positive. And it is here then the avidity comes in the play. High IgG means more than 6 months, low avidity means less 3 to 4 months. So if IgM is negative, IgG is positive, it is a past infection, but that does not mean she cannot get a reinfection or reactivation. We have to repeat this IgG in about 2 weeks' time. At least doubling should be there for us to label it as EB infection. But once avidity is high, the sequelae to the baby is going to be lesser. This is what we will call conservation.
Good. So, as you very nicely elaborated this one, that the absence of IgM does not rule out infection in early pregnancy. It could have happened in the early pregnancy, and now the IgM is negative and IgG is positive. You always compare it with pre-pregnancy or first trimester reports, but most of us would do only rubella testing in early pregnancy. And you've already made the point about
And Chanchal, no guideline tells us to do a routine CM. That's
yes,
very clear.
yes,
So you
yes.
do it,
There's
you
a lot
put
of
your foot
debate.
into the mouth
Yes,
and get into problem.
yes, yes, yes.
Because
Because
in this case, you already have an ultrasound finding. So
absolutely.
I would go straight away for an amniotic.
Yes, yes, yes. So, Dr. Savita, am I audible or is the echo back? So what else would you look for on the ultrasound, Dr. Savita?
So on the ultrasound, we'll, as usual, we'll do a detailed evaluation of the fetal brain, look at the ventricles, and look at the walls of the ventricles. Look for any subependymal calcifications. Look for the intracranial signs suggestive of fetal infection. So look at the ventromegaly and the signs of intracranial calcification. Also, if the lesion becomes severe, it might lead to severe ventromegaly and disruption of the normal anatomy of the fetal brain with very severe infections.
Would you like to comment on this?
So,
I'll just play it again.
So we can see there are calcifications, calcific nodules, and mostly there will find in the areas wherever the vessels are running. So there's this vasculitis which is going on, which leads to all these calcifications, and which will be seen as echogenic foci on the ultrasound.
You're absolutely right. That this is actually vasculitis, which will later get calcified and probably lead to parenchymal excess. So this patient did not have a ventriculomegaly. So what would be, Dr. Seema, what to do next? Should we wait for a repeat serology? Should we do an avidity? Or should we go ahead straight to invasive testing?
I think the best is to go directly for invasive testing rather than doing the maternal investigation. And the reason being that if we consider that this is because of some etiology that has already happened, so the infection is old only. So we should directly go for the invasive testing, excluding the CMA and the infections and everything.
So it happens often that there is a finding, ultrasound finding, but people are doing paired sera, and then they're waiting for avidity. But once the fetal manifestation is there, you just need to see IgG. If the IgG itself is negative in the mother, then she's never had CMV. But if her IgG is positive, that can very well be the cause of this this finding on the ultrasound. And one more question, Dr. Seema, that many times, because parental care screening, we have this finding on the ultrasound. Should you do a parental carrier screening for cystic fibrosis, or do you look for cystic fibrosis straight away in the amniotic fluid? What would be the correct protocol?
Actually, the best should be the trio, but as you know that the cost is always a concern. So generally, what I do, I just try to exclude the delta F508, and that excludes 35 to 40%, because there is a, so I counsel the couple that in Asian subjects, this accounts for 35 to 40%. The incidence is not as high as the other, Caucasian population. So we restrict to this much also, and we tell them that, so generally, here we would be doing on both the amniotic fluid and the parents.
That would be ideal. And right.
Yeah.
This lady, we did an amniocentesis, and the CMV PCR was positive on the amniotic fluid. So any role of antenatal management here, ma'am, Dr. Gujral?
Yes, Chanchal, there are some studies which are telling us that you can treat the woman with valacyclovir. There's a 2016 trial, which is the older one, which did say that you give the valacyclovir to the dose of 8 grams per day, which is 14 tablets. 90%, you're quoting the trial, 90% was the adherent, and the fetal infection asymptomatic neonates were 82% versus 43%. This is a 2016 trial. There are 2 other small studies, 20 and 21, where they have given this in the first trimester, and they have found that the amniotic fluid PCR is a 70% reduction. So that's the data as of now we have, though it's currently not being used. Then there is some data on hyperimmune CMV specific globulin, which is there. This is what we've already quoted, 2016, and the 2021 I've already said. Then the CMV hyperimmune globulin also has been tried in small studies, but there's a trial in 2021 which is called as a CHIP trial, where they recruited 124 women between 5 and 26 weeks, recent primary CMV diagnosed infection, separated, and they gave CMV IVIG, 100 milligram per kilogram monthly every 4 weeks till delivery, and they found that there were similar rates of congenital infection in newborn symptomatic, similar a percentage of symptomatic infections, and there was no difference in viral immunological of the infection. Therefore, that trial did say that gamma globulin, this CMV specific hyperimmune globulin, does not work. But what was the flaw of the trial? They did not look for sensorineural deafness, which is a commonest sequelae of the CMV infection. Had these babies been followed, or maybe followed, I don't know, because it's a recent trial only, then only we'll know whether this globulin works or it doesn't work. So as of now, barring 2 studies on valacyclovir, we have nothing else to offer to the women to decrease the congenital infection.
That to a certain carefully selected group of patients, because once they have severe cerebral ultrasound findings, then I think they promote.
Because in the trial, the woman who did not have cerebral findings responded. They separate into cerebral findings, non-cerebral, and the woman who responded did not have cerebral findings. So I don't know when you have cerebral findings whether all these are going to help or not. But as of now, it's not a strong recommendation to treat. You can just discuss, and try on the patients if that is there.
So this patient now, she has CMV. There are several findings, and she does fit into the moderate inclusion criteria. But however, valacyclovir, it is still not recommended to be used in mainstream. It is still, as per the current recommendation, this is the only drug we have available, and the guidelines have still not endorsed its routine use. How would you follow up this patient, Savita? What would you do? These parents want to continue, then what does one do? Savita, we can't hear you.
Unmute yourself, Savita.
So, ma'am, so that we can see how severe the signs of infections are evolving. So we do a 2-weekly ultrasound, and we can do an MRI at 32 weeks, which will be very helpful in prognosticating and deciding and counseling the patients. And that is how we'll follow them up.
This is one situation in which the MRI has to be done in the 3rd trimester. We should do it. And they do say that if there are cerebral signs despite treatment, discuss termination. And that, as Dr. Prashant mentioned, that the NTP Act has recently been modified. So we can pursue termination at a later gestation once permission is granted from an appropriate medical board. If there are no severe cerebral symptoms, the delivery would be at term. And there, despite treatment, there remains a risk of sensory neural hearing loss. So, Dr. Prashant, what would be your counseling regarding neonatal management and long-term outcomes in these cases where fetal CMV is proven and I have cerebral ultrasound findings?
So again, as you said that there are cerebellar findings. So first, let me take if we don't have a cerebral ultrasound finding. So in that case, the chances is very low. You know, people have studied that the MRI, the prenatal MRI, and the extended neurosonogram are not showing any abnormality. Then the chances would be say somewhere around 1 to 1.5%, and of a severe disease is almost 0%. So if we are thinking of doing a study where we are giving prenatally valacyclovir to the mothers in this group, so I don't think we are actually targeting people who will actually need that. So that premise of the study, I am not very sure that they are actually targeting the right population. But however, the question to me is that what will happen post-nip? So again, as Dr. Gujral ma'am has rightly said, that the timing of the insult is the decider, you know. So if we have a first trimester affection or early second trimester affection, the chances of having significant abnormality would be somewhere around 15%. So this 15% can have significant abnormality and they can be perinatal death also in almost 4% of cases. If we have these abnormalities, which can be there in the form of not only ventriculomegaly, but migrational disorders as well. So if it is early in the pregnancy when my cellular migration is happening, then we can have all these polymicrogyrias happening, perisylvian polymicrogyria, sometimes Stresencephaly, all these abnormalities can be there. If it is just ventriculomegaly, then also the possibility of having white matter abnormalities and presenting as cerebral palsy with seizures, this is there, along with chorioretinitis. So then the chances of having, as you rightly said, that if there are abnormalities that are picked up by this 32-week MRI, then you need to offer them that possibility of having abnormality is going to be very high.
Yeah, so Dr. Prashant, I have a question because as you know that the CMV is common in our country, where both the primary and the reinfection. So how do you recommend newborn screening? Because there are data available that a newborn screening for CMV infection. So how do you, what are your...
So see, what we do is that actually for 100% accurate diagnosis, you can do it only once the newborn is there or within first 3 weeks, if you are able to get it done. Later on, so it is not routinely recommended to do that. If you have already some antenatal signs which were there in the ultrasound, then maybe you will have to repeat it, and there also just proving that there is a positive IgG or an ability which is there. It's more important to repeat a postnatal image and see whether those findings which were detected prenatally, they have persisted, they have regressed, or they have increased. So the postnatal imaging would actually decide the outcome. So if it is not there, then I just need to follow them closely, put them under developmental surveillance, screen them at certain point of time point, and see whether the outcome is there appropriate at 2 years or not. But routinely, there is no recommendation, at least I'm not aware.
Yeah, there are papers, you know, which suggest that, you know, the newborn screening should be done because CMV is a common infection.
But
so
because it is so
because
common,
this is treatable also. So
it is so common, ma'am, otherwise you will end up treating a lot of patients. So the number needed to treat one actual patient would be quite high.
So any high risk cases, like, you know, sometimes, you know, I would get HLH and there would be suspicion, you know, that this was, this can be genetic too, and this can be non-genetic too. So this is where, you know, I get caught up that if the CMV was confirmed probably by the PCR, then probably it would have been a better. Otherwise we'll be doing lots of genetic tests. Yeah.
If microcephaly is there, along with temporal cyst and ventriculomegaly, then the chances of having CMV would be more than other genetic disorders. Else you can have some sort of a lesion-Kefli-like pattern, which can have a genetic predisposition. So based on postnatal MRI, we can have some clue whether I should go towards an infective etiology or I should think of a genetic etiology upfront. But if I see that maybe sometimes MRI also is difficult to pick calcifications, we do a CT at times. If we see that there are periventricular calcification, there are temporal lobe cysts, there is ventriculomegaly with white matter hyperintensities, we are more sure that it is CMV only.
Yeah.
But I agree that in an individual case, it might be a issue, but this is how we go about.
Yeah. Yeah. So at least microcephaly and it should be done, because we had recently had a case where the child has come for mother has come for previous developmental delay, and microarray, whole exome, everything was done. But when I reviewed the record, I realized that, the CT scan has lots of calcification and there was in utero microcephaly. So I'm dealing with a non-genetic cause. So at the same time, we have to highlight the non-genetic causes also, because they have less recurrence risk. So
we'll quickly go through the last case, ma'am. Do we have time?
Yeah, we have time.
Yeah. So 28-year-old fourth gravida. This is para 3, but only one live issue. She came to us at 23 weeks. The first male child, she had a full-term normal vaginal delivery. It was a 3 kg baby, but was found to have congenital cataract, global developmental delay, and slow motor movements and recurrent pneumonia. And this child expired at 1 year of age, and the cause was not established. In the second pregnancy, she again had a male child, a term cesarean, who was alive and healthy, and when she came to me, he was 8 years of age. The third male child, again a term cesarean because of previous cesarean, but had similar findings to the first child: congenital cataract, global developmental delay, sluggish motor movements, recurrent pneumonia, and the postnatal MRI reported cerebellar hypoplasia. This child also expired at 1 year of age. Now, this patient has come to us for an ultrasound, and she's 23 weeks. And Savita, would you like to comment on these images?
Yes, ma'am. So in the axial section, when we see that the lateral walls of the ventriculars are looking slightly irregular. So these irregularities in the lateral wall of ventricles could be the most likely cause. Could be there's this nodules, clusters of the neurons which are not properly migrated, leading to these irregularities in the lateral ventricle. So this looks like periventricular heterotropic nodules. So when the neurons are migrating, if they do not migrate properly, so they form these nodules, and the most common is periventricular heterotropic. But we also have other possible DDs in this case could be tuberous sclerosis, could be hemorrhage, and CMV infection. Tuberous sclerosis will see tubers other parts also, like in the heart. In the infection, we'll see the calcifications, and if it's hemorrhage, we'll see clots in the ventricle. So, but this looks like periventricular heterotopia.
Right. So now, given the history, this ultrasound finding, so Dr. Anita, what would your counseling and antenatal management be?
Patient already has previous to cesarean section. She had 2 previous affected child. So there seems to be a genetic predisposition, and this child also in the ultrasound is showing already some changes in the posterior fossa. So we have to really the patient whether she wants to continue with the pregnancy, because in both the previous affected child, the baby anyway passed away at 1 year of age. So if they want the termination of the pregnancy, it can be offered to them right now. And if they want to continue with the pregnancy, they have to be able to counsel about the option. And the counsel have to be done.
Right. So, but she definitely needs both Dr. Seema and Dr. Prashant. So it was a very difficult case to deal with, because the rest of the baby looked absolutely okay. And so Dr. Prashant, would you like to counsel her now or after a detailed workup? Would you want to comment on these subtle findings? As I said in the beginning of the panel, it is these subtle findings which have become a pain. Otherwise, the baby looked absolutely okay. In fact, on transabdominal scan, I did not even see those bumps, but once when I did the transvaginal, those tiny little bumps were there.
So there was no cataract. There was no cataract.
There was no cataract. There was no cataract. There was no cerebellar hypoplasia, which were the findings in both previous children.
Yeah, so that was the most positive outlook towards this baby. Yeah.
Right. So Prashant, would you want to counsel now, or shall we speak to Dr. Seema first and then take a call?
We can have both our opinions. In fact, this is the actually the good part, that we are so with diverse disciplines, and we are all together and discussing cases like this. So what I'll take inferences from the two histories that you have given me. So what we have is a congenital cataract, we have global developmental delay, and we have some sort of recurrent pneumonias happening, and the repertoire of movement is quite less. So this brings me that maybe I'm dealing with something which has got both an upper motor and lower motor neuron type of affection. And the possible differentials that would come to my mind would be a form of some congenital muscular dystrophies, some dystroglycanopathies, and there would be certain syndromes. If you tell me that there was some dysmorphism also was there in the previous kid, whether that was documented or not. So then, in fact, Dr. Seema herself has published one case with micro syndrome and all, which can have these abnormalities.
A genetic syndrome, torch mimicry torch. Yes.
Yeah.
The title is that only, because there was congenital cataract. Yes.
So you can have, and along with that, then maybe I'm not sure that whether the previous MRI actually was read appropriately, and whether some simplified chiral pattern was also there. If that would be the case, then I would look at other genetic possibilities like ARX, TUBA1A, which are the genes that are associated with Lesion-Kefli and then can have cerebral hypoplasia. They can have cataract as well, or a Marinescu-Sjogren syndrome that we see as presenting to us with plasticity and congenital cataract with global developmental disease. So the possibilities as a neurologist is quite big, but majority of them are going to be genetic only, and we all know that now it has recurred twice at least, so the possibility is high. Now, if we see at this case, which just has heterotopias, and we has not carried the baggage of the previous kid, which has all the other abnormalities, I'll not be very happy, in fact, because I know that maybe in a later imaging, we might see some of these abnormalities. But currently, I would consider it that possibly there is some sort of a migrational abnormality, some sort of a Lesion-Kefli is there, which, and along with this heterotopia, I'll counsel them that this kid may have seizures to in a early period or maybe later, along with developmental delay. This is my possibility. Seema ma'am would love to hear from you.
So actually, because now we know that this is genetic only. This is not non-genetic. As you know, in a congenital cataract, rubella accounts for 1/3 of the cases. But now we are not dealing with the infection. We are definitely dealing with some genetic disorder. And the differentials, as you said, that for me, the Warburg micro would be the top, as you know, because I have published. So the Warburg micro, so I put all these into the differential, the galactosemia, then the Lowe syndrome, because all these are commonly seen syndrome with the congenital cataract. So
Cocaine as well, ma'am. Cocaine syndrome, the mitochondrial.
Yeah, the dystroglycanopathy, which you mentioned. So we ordered the whole exome sequencing, and this time we wanted trio, like the mother, father, and child. But then I knew that this baby has gone to Gangaram, so they see the they anticipate the problems, the need of the prenatal diagnosis. So the DNA was stored, and they were quite kind to give us those DNA. And this DNA, along with the parental and along with the fetus, everything was sent. And then we had this mutation, and which was homozygous. And as per the available literature, this was uncertain significance. And so how to interpret this? So we correlated this, and this has this fitted clinically. So whenever we have this kind of report, we have to see 2-3 things which are important, that whether this is pathogenic. So in this case, this is reported as uncertain significance. So we need to do the segregation analysis in the parents to see that whether this is coming from the parents. So 2 important things: the clinical correlation and the segregation analysis. And on the segregation analysis, the parents were heterozygous carrier. So now this will be labeled as likely pathogenic. So just doing the parental analysis helped me in knowing that this is likely pathogenic because this is coming from parents, and also the literature is supporting that this disease is associated with the congenital cataract. So the fetal testing was done, and the fetal testing was entirely normal. And so after that, I think the Chanchal has the history.
So now this, as we've already discussed MRI, we would want to do. And at 23 weeks previous to cesarean, unknown prognosis, the parents, the termination is also has its problems. And they were keen on getting further workup done. So we did all this exercise, and then an MRI was done. And these are the MRI findings, Prashant. I'm not sure how well you can see them, but you can see these. Would you like to comment on this? These are not great images, but
I'm not an expert at reading fetal MRIs, though. But what I see is that there are some these speck-like nodular hyperintensities which are there. So I would take them that these are some big nodules which are there. But apart from this, there is some dilatation of the ventricles, maybe, which is evident here. But apart from it,
yeah, it's. I'll tell you the report. So I just wanted to show that these same dots that we are seeing, which were projecting into the ventricle, there was nothing in the gray matter. There was no. These were the only two findings that were there on the fetal MRI. The MRI was done at around 32, 34 weeks, and the rest of the fetal brain was reported as normal. And with because the whole exome was normal, we did have a pediatric neurology consultation. And as you rightly said, that it is in context of investigations. Does your counseling change, Prashant, after this information that the whole exome is normal and the MRI is not showing us anything new at 34 weeks? What would you tell the parents? Because by this time, because all this workup took 6-8 weeks, by that time, I think 28-30 weeks, the parents had made up their mind that we'll continue. And that's what the treating team was also.
Yes, Dr. Chanchal, I would definitely then revise to some extent what the previous counseling that I gave, that the possibility of seizures and cognitive abnormalities was high. So then in this context, I'll say that what we have in the previous kit, we are not seeing those abnormalities here. And the possible genetic evaluation, which we could have done, has also not shown any abnormality. So in that context, the possibility of having some seizures would still be there, because these heterotropias, these are quite epileptogenic. So the chances of having seizures is going to be there. But apart from that, we may not be able to comment more on the developmental aspects, as we were considering based on the previous history. The amount of sinister thought process that was there with me, I might not have that. I would tell them that seizures can be treated with anti-seizure drugs, and these heterotropias can be amenable to epileptic surgery as well. So this is how maybe I'll proceed. But I'll want, in fact, ma'am's opinion that once we have detected this, which is an autosomal recessive variant and in a heterozygous state. So are we sure, ma'am, that this is going to be the reason why the child is there, or there can be an add-on deletion or duplication which is there?
No, this baby didn't have any mutation. Baby was entirely normal. The proband has a homozygous mutation.
Okay.
So I clarified with the lab that is this baby heterozygous also, the current baby. So they said because because this was deletion, so the sensitivity of NGS based analysis is not good for the heterozygous pickup. So they said this is either heterozygous or entirely normal variant. So but my question to Dr. Prashant, because there is a periventricular heterotropia, as we know that even the CMV, as you know, I'm too much for CMV. So, so do you think that CMV screening would be good for this baby?
So that would be one hypothesis that we will eventually.
Yeah, because we see,
Exactly. I fully agree with you, ma'am. That would be one event, because we have exhausted the genetic evaluations which have not yielded anything. So a possible etiology would be an underlying CMV infection. We would like to screen the hearing after maybe 3 months from birth, so that we are very sure that this is not there.
And suppose the baby is CMV positive, you would like to treat with Gynecological?
No, ma'am, there is no active infection which is there.
Okay.
So if there is active chorioretinitis, if there is active ventriculomegaly, hydrocephalus, there is ventricular sloughing, that is the time when we'll actually go ahead and treat. Or there is a hepatic dysfunction which is seen in form of raised enzymes. So we don't see any active disease here. So there is no point. Heterotopia will not go. They're not. This is a structural malformation that has got created. So treating with valsiclovir is not going to help us now.
Okay. Okay.
The record cesarean was done for this lady at 38 weeks. She had a baby girl, 2.8 kg, and she's still on follow-up. She's currently 6 months of age, and lucky for the parents as well as for us that this child has not had any episode of seizures so far. They come from somewhere, some remote part of UP, so they've decided that they will come back at 12 months of age to get an MRI done. We have not had as yet had a postnatal MRI. So far things are looking okay. So with this, I would like to conclude this session. The take-home messages was that it is very important to understand that the CNS abnormalities, they may manifest later than the usual 18 to 20 week anomaly scan window. So probably if we really want to do an extra scan, it would be at the 24 weeks. And as Dr. Savita, she routinely says that it should be mandatory that a transvaginal scan at 24 weeks, because it really gives us information about a lot of subtle findings in the brain. And a transvaginal scan, as per published literature in the mid-trimester, is by a trained expert is comparable to MRI. An MRI may not be universally available to everybody. And even where it is done, people may not be adept. So we are constantly evolving in our imaging modalities and their interpretation. Important thing is that not all findings warrant termination. So it is a multidisciplinary management. We all have to put our heads together and then counsel these parents so that we walk that fine line between unnecessary terminations and a blind carrying on with pregnancy and dealing with these children later on. With that, I would like to thank all my panelists. Thank you very much. And thank you, Dr. Seema.
Thank you, Chanchal.
Making this possible. Thank you, Dr. Tina, for bringing us all together.
Thank you, ma'am. There are some questions in the chat box. Dr. Divya Patel has asked, any experience with herniated Dandy Walker malformation, any genetic marker? Seema, ma'am.
Yeah, Dandy Walker can be non-genetic and genetic as well. So as you know, that, first for any genetic investigation, we would do microarray first, and then followed by if the microarray is normal and if the suspicion of genetic etiology is high. So, the suspicion of genetic etiology, we take the family history, if there is a previous affected child or if there is a consanguinity. So based upon that, we decide the testing. If there is no family history and no consanguinity, microarray would be the first choice. And,
okay. Vanna, ma'am, what is herniated Dandy Walker malformation? Vanna Chadda, ma'am. Ma'am, you're muted.
Shari malformation, and herniated Dandy Walker malformation is not a term I'm familiar with. But Dandy Walker, yeah, so maybe Dandy Walker malformation typically would not have any particular herniation, but Shari malformation will have herniation.
Yeah. Anyway, it is a lethal malformation.
Yeah.
The other question I'm seeing is a CP small. Read that paper.
Your voice is breaking. Vandana?
Yes, ma'am, your voice is breaking.
The paper by Palladini published last year in 2020, if some of you have read, where he has correlated very large CP persistent CP with some neurodevelopmental delay. So that is a recent publication in the White Journal, I think. So if some of you want to just look at it, and in my own
size given.
Yeah, so the size is bigger, the persistent and the bigger sizes. My own experience, very few, I think I remember 2 or 3. We have done some sort of follow-up, but I haven't found any.
Yeah. Most of them have regressed 26 weeks.
Also the definition, one careful in small irregular cysts as CP cysts. So that should be clear.
And I think Dr. Chanchal, she's around. She had one referral for CP cyst and where she could see. Dr. Chanchal, can you share your case?
Yes.
Unmute yourself. Yeah.
I'm unmuted, ma'am.
Yeah.
I'm unmuted.
So your case where you
Yeah.
could see the referral for CP cyst and where you, yeah. So if you can.
So, ma'am, it was referred as a choroid plexus cyst. The one, Dr. Vanna, the publication that you're mentioning, that CP cyst was more than 2 centimeters and it was compressing the ventricle and it was causing ventriculomegaly. We did have a referral for choroid plexus cyst, but it was more like a uterine synechia. So we did the amnio and the same, though infection serology was negative. So now at present she's awaiting an MRI and probably it is not a choroid plexus cyst, but a arachnoid cyst. So we're still unsure about the diagnosis.
There's one question about MRI. Dr. Doda, can we do fetal MRI with 3 Tesla or with 1.5 Tesla only?
There is absolutely no problem. There's absolutely no problem. We have done all our cases on 3 Tesla MRI. The studies have been done on 1.5 Tesla and they have found no harmful effects whatsoever. Of course, the studies on 3 Tesla have been very limited and so far not very conclusive, but it is generally presumed that 3 Tesla has, equally sort of no harmful effects.
Thank you, sir. There's one more question. Why partial agenesis of corpus callosum is a bad prognosis when compared to complete ACC? What is the reason? I think Dr. Prashant has already explained it very well. Do we need to revise?
Yes.
Okay.
No harm.
Okay.
Prashant?
Yeah. So again, there's not much of a clarity is there. But what happens here in partial agenesis that there is an element of an acquired abrupt insult which is there. So this insult will lead to additional damages. So possibility is there that because of this, the severe neurodevelopmental abnormalities is there. And then somehow, because of unknown reasons, even the chances of having a chromosomal abnormality is slightly more here compared to a complete CC agenesis. So possibly these are the 2 reasons why we have more neurodevelopmental abnormalities with this. But we need to understand that this information is coming from studies which don't have a very large sample size. So how much we can actually extrapolate it to our general practice, this is of something of contention. But yes, this is what the results.
Can somebody point out about the outcome of Dandy-Walker variant? Not the full malformation. Dandy-Walker variant is supposed to be a milder abnormality.
The published literature has very few studies, but the 1 or 2 which are available, usually they counsel almost in the of FOGSI. So if you do a complete workup and there is nothing else or an extra CNS malformation and the microarray is normal, then one would expect 80%, 85% normal neurological outcome and 10 to 15 have some delay, but the very literature there. So again, I have 1 odd patient where there was epileptic fit and even a neonatal demise in a partial Vermeer age.
Can I make the comment here?
Yeah, please.
Yeah, please.
So the Mellinger group, they what they have suggested is that we should stop using the term Dandy.
Yes.
What they're saying is those differentials of the posterior fossa cystic space, which includes the inferior verminagenesis, Blake's pouch, and the frank Dandy-Walker, not the variant, and the megacystana magna. They're suggesting that you should use that terminology rather than using the Dandy-Walker variant.
Yes. Now, the Dandy-Walker variant, yes, they say that it's obsolete. We should only use Dandy-Walker malformation as a term. Yes. Ma'am, I'll request Dr. Any more question? Megacystana magna invasive test. Does it require counseling?
I think this confusion about what requires invasive testing, I think it is our own made phenomena. With the advent of the microarray, 0.8% of everybody will have a microdeletion of duplication, especially so in these subtle findings. So I think that invasive testing, we are very clear about what requires invasive testing. A megacyst and a magnet typically may not have an association. It's not recommended, but there is, I think the parents should be given that option, that there is this finding. We can provide you more information about your baby, which should be given to everybody. Dr. Seema and Dr. Vanna,
I think, whenever there is a finding, the option of invasive should always be given, because even without finding, you can have genetic disorders. Even in absolutely normal fetus also can have Down syndrome. So I think it's always that option should be given to the parents. They should be, discuss about the limitations of the ultrasound.
It's not as straightforward as a high risk of for trisomy 21 for combined first trimester.
It can be offered. It's not recommended, but yes, it can be offered.
So in Mark Ivan's words, that for me, what he says is, for me to recommend invasive testing, I need only 2 conditions. That the patient should be a woman and she should be pregnant. So because of the availability of microarray.
And I feel, if there is any marker which you are doubtful, that gives us an opportunity that probably, there is something more beyond, our normal understanding. So I think it's always better to give the options.
Very non-directive. We should be very clear. Invasive testing is it does give us information, and we do have that option. So they should.
So
may I come in?
Yes, please.
Actually, this is a curious question, in fact, to Dr. Seema and in fact all others. To see, as a neurologist, I see this option of getting a genetic testing in a different perspective. So what if I see that there is some abnormality, but then we all know that there is a different level of penetrance, there's a different level of clinical, the spectrum is quite wide. So do we really want to identify something about which we actually don't know what has to be done? So the more we test, the more we'll identify. So in this quest of actually finding solutions, are we going ahead and finding more problems for them and for us also? So we might not have an answer for a variation of unknown significance, or a copy number variation, which might not be we are not very sure on the outcome.
Yeah, so that's why, the pre-test counseling is required, Dr. Johri, because whenever we offer all these, we tell them that what are the expectations of this test, what are the limitations, and what if, the test becomes inconclusive. So, we need to test the parents. So all these things, we have to, inform them as we are informer only for them.
So ma'am, Prashant has actually hit the nail on the head. That is my other problem with invasive testing. It's being interpreted by I don't know whom. We have the option of having you as a backup, because this WOOS is a nuisance. And I've had this discussion with Dr. Vanna also. The labs find it easier to just report anything that's seen.
Yeah.
So we actually need a more consensus reporting and some guidelines to report. Reporting a 220 kb duplication in an amnio done for high risk on quadruple when the baby looks okay, because the parents will very happily terminate. Yes, we found a problem.
Yes.
So these are the 2 extremes. So invasive testing has its merits, but the indiscriminate and reckless reporting is going to make it into a disrepute.
Yeah, so we need a standardization. We need guidelines. I think we will have to work harder so that we make a guideline for our own settings. But if we remember that there is a guidelines for them, internationally, that anything which is more than 50 kb, that should be reported in cases of the deletion. So, and for the duplication also. So I think their international guidelines are there, and they are probably following that also. But there are many actually, why the problem is arising. I looked at with my scientist friends that why this problem is arising, because we don't have normal data. So this will take some time, because if you remember when the microarray came, there are lots of WOOS reports. But now over the age, there is a learning curve for everything. So now with growing years, the number of WOOS has decreased rather with the microarray. So this is all because, we don't have the normal control data.
So when we offer microarray in our center, this, that we tell them that we give them an option that WOOS may not be reported.
Yeah, WOOS should not be reported, yes.
So the parents click that option and after counseling.
Yeah, that is important. And ideally also in the prenatal settings, the WOOS should not be reported. So
any other queries or questions to be discussed? I think
we have done.
It was a
I think
mind-boggling session, ma'am. I'll request Seema ma'am to conclude the session for us.
Yeah. So it's an opportunity to thank everyone who made us, to work together, and especially Dr. Doda sir, the Doda Diagnostic, our faculty, both the chairpersons, panelists, speakers, who made this, academic discussions very helpful for the obstetricians, so that we can improve upon our practice. And last but not the least, the Shivam and Mr. Himanshu, who has been helpful in smooth running of our, the technology part. So thank you, everyone. So
thank you, Ma'am Seema and Dr. Tina, for inviting us. It was really enriching.
Thank you, Dr. Jay.
We enjoyed every bit of this. Thank you.
Thank you, Dr. Vanna.
Thank you, everyone.
Bye, Chanchal. Bye, everyone.
Thank you.
Yeah, we had pictures. Just 1 minute. Himanshu, we want a group picture, though virtual.
Sure, ma'am.
Tell us when you finish.
Done, ma'am.
Yeah, thank you. Thank you. Bye.
Thank you. Bye.